Hi, good morning. Welcome, everybody. Let's be seated. Okay, please find your way to your seat. I'll just say in this section back here, we're not having anyone sit in that section back there. So you can clear out. You seen Irina? Okay. Join me on stage to welcome. All right, let's be seated. We will begin. Good morning. Good morning, everyone. My name is Efikona Nuer. I am the chair of the Occupational Therapy Program. And myself and my committee members, Dr. David Kaufman, who will introduce himself, Professor Irina Struck, who will be down shortly, and myself, we've been coordinating today's events. And I'm so happy that we're all here today to celebrate the scholarship and research within our school and interprofessional collaboration. We have a full program for you today, and I'm very excited to have and share knowledge across the school. So before we get going, I just want to give Dr. Kaufman a chance to say hello, and we'll get right into the program.
Greetings, folks. Thank you all for coming. I much appreciate it. This is a really exciting day. You know, we don't get much of a chance to get together. And frankly, you know, as in all schools, we're a little bit siloed. So I really look forward to hearing different faculty and different students' presentations and reviewing the posters. Posters look awesome. I'm very grateful for the occupational therapy students who are helping set them up. It's an immensely valuable role. If you've ever tried to put up your poster yourself, you know the experience. Thank you again.
Okay, before I invite Dr. Alan Lewis, the Dean of School of Health Professions, to the stage, I just want to say my thanks to everyone. This is going to be a really robust day, and there's people to thank that I would be remiss if I didn't. So all the abstract reviewers, the poster judges, the Dean's Office for their support, facilities and management, Cafe 101, all the people working behind the scenes to make this day possible so that we can come together and share with each other. So I just want to make sure I give my thanks to them. So without further ado, I will invite to the stage Dr. Alan Lewis. Welcome.
Good morning. You guys know I don't usually speak with notes or slides or anything, but today I thought I'd have one slide. Since it's research day, right? A little more formal. Good to see so many people. And of course, students, as per usual, you're all in the back. Nobody wants to sit close. But we're happy that you're here. And we also probably have some people on live stream who are also joining us. So, you know, as Dr. Neuwer said, and Dr. Kaufman, Research Day is very important. It's interprofessional. It allows us to have a culminating experience with all the research projects that have been done this year. And all of our programs have that requirement, so it's good to talk research. So what I'm going to do is take about 10 minutes max and talk about research and scholarship being the lifeblood of health professions. Now, I know I don't have to explain to you health profession students about how important blood is to the body, right? So I use that metaphor, lifeblood, to talk about the importance. Now, I know you all have research methods, and one of the things I was telling Dr. De Oliveira earlier is that we don't have a lecture in that course yet. We're going to add one soon. that clearly distinguishes research from scholarship. Because for the most part, we use those two terms interchangeably, research and scholarship. I kind of blend them together as much as possible. But they are a little bit different. So research, as we all know, generates new knowledge. It's engages in discipline inquiry, so it's a pretty rigorous process, systematic. Even if it's qualitative, it's very systematic in how it's done. And it's pretty narrow in focus. But the role of research is to generate new knowledge, as we know. So we wouldn't know anything in our professions were it not for research. To be distinguished with scholarship, which is very similar, but really talks about the understanding that we take from research and how we apply that understanding to improve our specific professions and our clinical practices. So we use those results to inform that practice, use those results to teach others how to inform their practice with research results, and then we use whatever we learn from our own discipline as well as other disciplines to actually infuse that into our knowledge about what works in our practices. So research and scholarship, very similar. Again, we use those very terms interchangeably. But research is the process of generating that knowledge. Scholarship is really taking that knowledge and really making sure we have understanding and we infuse it into the various fields that we're working in and disciplines. So number 2 on the slide there. You all, when you graduate, one of the things that you'll know very soon, and I've been talking about this topic since 1990 when I worked in state mental health. And when you go out into the workforce, all of you as clinicians or health professionals will be faced with a set of what I call countervailing demands. Demands on all sides of you. They'll be encroaching upon you as a healthcare professional. Don't be afraid. It's just the world we live in. But those demands are increasing demands for services. We all know that there's no shortage of people who will be knocking on your doors asking for your services. And that's largely driven by population increases. The population never isn't increasing. It's always increasing. So right now we're at 340, maybe 350 million people in this country. And by 2100, based on 1999 census estimates, I think they projected that by the year 2100, I'll be long gone. I'm not sure who else here will still be around, but probably some of you might be, maybe not working. But by 2100, 75 years from now, we're supposed to have in excess of 500 million people in this country. I have no idea where all those folks are going to go, but they're going to be here. So the point is, when you're working in healthcare, there are always more people to serve than you have time to serve. And we know that the population is also increasing in its diversity, which means that the tools you need to serve one population aren't necessarily the tools that work with another population. So you've got to be very adept at understanding cultural differences. So that's the first demand. And so demand is on the increase in terms of services and the number of people who are asking for your services. But we also know that resources to support services never keep pace with that increasing demand. They're always behind. So the resources we have to deploy to provide healthcare services is never at the same level, never commensurate with the actual demand that's there that we're trying to address. So that means you've got to be very good at your jobs to make sure you stretch those resources that are pretty limited as much as possible. And you'll have accountability from 2 perspectives. So your clients, patients, service recipients, whatever you want to call them, they're going to hold you accountable because obviously in 2025, people have access to the same information you do. They're not as expert as you are in your disciplines, but they certainly can know a lot about whatever their presenting challenge is. And so that means it's not like 75 years ago when you went to see your healthcare provider, a physician. You didn't know anything. They were all knowing, and they felt like they were God because anything they told you, you had to do. You didn't have any other knowledge. But that's not the case now. When I go see my physician, who's a Harvard-trained MD, PhD, she knows this. And so what she'll say is, Alan, these are the 3 things I want you to think about doing. Which one are you really going to do? And because she knows I've already done my research. I know not as much as she knows, but I know enough to know the questions to ask and to keep her honest in terms of her knowledge. So that's what you're going to face, a very empowered, a very self-determining population of patients, and their family members are also going to be that way. So you got to know your stuff. And accountability comes from another source, which is from payers of services. Now, payers of services are all of us. If you pay taxes, then your dollars help support public services as distributed through executive branch agencies to support whatever services that the state or the city or the government in some cases may provide. Also, if you pay for insurance premiums, then you're a payer. So insurance premiums are based on people paying them, and everybody shares that cost. So that means your accountability would come from that group because, you know, we really don't like having to pay more taxes or higher insurance premiums. So we really want whatever we're already paying as taxpayers, as citizens, and whatever we're already paying to our third-party insurance provider we want those dollars to have a greater reach, to have more scope than to actually ask us to pay more. So those 4 demands that are going to be on you all the time as you go forward as a healthcare provider. As I said, I've been talking about this since 1990. I began to acknowledge and see these things in health professions back in 1990. This means that you got a mandate, an imperative as healthcare providers. You've got to be able to provide services within lean and limited resources, which means you've got to be able to provide services that are always effective. You cannot afford to be ineffective in anything you do because then you run the risk of wasting precious resources that you don't have the option of wasting. So you got to be on your game, you got to be good at your game, you got to be very effective and very efficient in how you provide those services. Because people are going to be asking you about outcomes. I'm willing to bet, and I know that some employees do this. They say, well, is Andrew here from PT? I'm trying to think of some students' names I know. I'll use Andrew, whether he's here or not. He's a PT student. And there he is. Hey, Andrew. And so, Andrew, imagine yourself a year and a half from now working for a PT practice, and let's just say they're paying you $150,000 a year. Let's just say for the sake of discussion. That'd be great, right? Be pretty good. So that's a lot of money. So what's going to happen at some point probably for all of you, whatever your salary is, your employers are going to begin to ask you, Andrew, we're paying you a good salary. We think you're a good employee, but show us some data that speaks to how effective you are to justify your salary. So how do we know that paying you $150,000 a year is really beneficial? And so you'll have to be able to say, well, you know, I had collected these data. My success rate is, 95% over the last 6 months in terms of successful closures or whatever your metric is, depending on your health profession. You can't say, well, I had that one client about 2 weeks ago, I did really well. And there was that other client 4 months ago, did really well. That's not going to cut it because that's anecdotal, isolated information. They're going to want to know in the aggregate how effective you are. So even though you may not worry about it as much with these demands, at some point, I'm willing to bet your employers are going to start putting that pressure on you and say, we're paying you X dollars. Show us some data that speaks to why we should continue paying that money to you because you're effective enough to actually be entitled to it. So you're going to be under pressure. Don't be afraid. It's just the world we live in. I've been in this world since 1990 when I began to think about it. Okay, so number 3 on the screen. So scholarship and research are really the lifeblood of health professions. Everything you know today about what works in your disciplines is based on research and scholarship that happened in the past. Without it, we'd have no tools. If somebody hadn't done some research, comparative effectiveness research and basic research to say we know these interventions work, you'd have no tools. You'd have no technology. You'd have no interventions that are evidence-based. But thankfully you do, because somebody has done that due diligence and done that research and scholarship in the past. Now, going forward, tools change. Evidence-based practice changes. So what will be efficacious and effective tomorrow depends on what we're doing today in terms of research and scholarship and in the future. So it's an ongoing process. So thankfully, we have that, but it's got to be a part of who you are as well. You've got to constantly be able to check in on the literature to see how evidence-based practice is changing. And then the third piece here, you got to be, as I just mentioned with Andrew, you got to be able to evaluate your effectiveness. So I'm of the opinion that you must begin to collect data as soon as you start your clinical practice. It doesn't have to be very elaborate. It doesn't have to take a lot of your time. You don't need to be an actual, researcher, but you do have to put together a spreadsheet that speaks to both objective indicators, those measures of how successful you are with your clients that are immune to client input and bias. Sort of like if somebody says, Alan, do you have high blood pressure? If you ask me, I say no. You gonna take my word for it, or you gonna look for an objective measure of my blood pressure? That's an objective measure, take my blood pressure. But you also, because you're serving people, they're customers, don't forget that. So you gotta have some subjective measures that you include as well, which is primarily satisfaction. You gotta know how satisfied people are with your services. And you also have to remember that people are pretty fickle when it comes to satisfaction. Because there's that one client or patient where you may walk on water and cure stage 4, lung cancer for them, they're still not satisfied. Then you have the other client who all you have to do is speak to them in a nice way when they come in, and they think you're the best thing since sliced bread. So satisfaction data is fundamentally pretty flawed, but because you're working with customers, i.e. people, you have to capture it. You got to know what people think of your services and your effectiveness, which is the objective data. You need both. So as healthcare providers, go out, deal with these stressors, these demands, but understand that research and scholarship is your lifeblood because it is the foundation of everything that you know that works today in your disciplines and the foundation about that to whatever will work tomorrow, what we will know tomorrow about what works. And that changes all the time. And those same tools you need to use to evaluate your effectiveness. So stay in the game and do as best you can. It is a difficult world. I'm glad you're out there, and I'm no longer out there. You guys are more equipped in 2025 than I was when I did clinical practice in the 80s. So it's been a while. Okay, with that, I'll say thank you again. Looking forward to hearing the projects today and the panels and the presentations, and let's enjoy.
Okay, welcome. I invite the panelists and the moderators to the stage. We have what I think will be a very engaging panel discussion on promoting pelvic floor health. It's going to be led by 3 occupational therapy students who have been working over the... Yes, that's right. They will be moderating the panel, and I'll let them introduce the panelists. All faculty and alumni of SUNY Downstate, so welcome back. Thank you for sharing your knowledge. So I'll hand it over to Kristen O'Regan. Thank you.
Good morning, everyone, and welcome to today's panel titled Promoting Pelvic Health, an Interdisciplinary Perspective from Emerging Areas. We're excited to have you here today as we explore pelvic health through the lens of multiple disciplines. This conversation is especially timely as pelvic health continues to gain recognition, not only as a vital aspect of physical well-being, but also as a deeply interconnected component of mental, emotional, and social health. Whether you're a clinician, a student, advocate, or faculty member, we hope you leave today with new insights, tools, and inspiration to support those who you serve. Let's get started by welcoming our panelists. She is an occupational therapist specializing in pelvic floor therapy for the perinatal population, using techniques like awareness training, breath work, and yoga, and treats conditions such as pelvic pain, prolapse, and incontinence. She is skilled at addressing the psychological and social impacts of pelvic floor issues and collaborates in the care of pre- and postpartum clients at Nettle Wellness Midwifery and Small Things Grow Midwifery. Moving on, we have Richard Sable, who is the Educational Director at the East-West Rehabilitation Institute and a Clinical Assistant Professor at SUNY Downstate's Occupational Therapy Program. He teaches his integrative approach at several occupational and physical therapy programs and divides his clinical time between private and community-based practice. Richard sees clients with pelvic concerns, movement disorders, brain injury, and chronic breathing problems. Our next panelist is Dr. Amal Amar Alatabi. She is a clinician and educator with nearly 20 years of experience in women's health, specializing in care for underserved and minority communities. Rooted in the midwifery model, Amal's practice emphasizes prevention, advocacy, and culturally competent care, and individualized care across the reproductive health spectrum. She is a clinical assistant professor and clinical coordinator at SUNY Downstate's graduate midwifery program. Last but not least, we have Georgette Polycarp here with us today. She is a certified nurse midwife and a family nurse practitioner from Brooklyn. She is also a certified Lamaze childbirth educator with years of preparing parents for labor, birth, and postpartum care. Throughout her nursing career, Georgette has been passionate about advocating about racism in healthcare. She decided to become a midwife to improve maternity care and outcomes for Black and marginalized people in New York City. As a midwife, Georgette's goal is to provide safe, culturally centered, and holistic care. Now I'd like to take a moment to introduce today's moderators. Joining me are May Takahashi and Kelly Powell, and I'm Kristen O'Regan. We are all second-year occupational therapy students in the master's program at SUNY Downstate, and we are interested in specializing in pelvic health. Currently, we're wrapping up our didactic coursework and preparing to begin our Level 2 fieldwork placements. Before we dive into our panel discussion, we'd like to start by grounding everyone in a shared understanding of what pelvic health is, why it matters, and how it impacts overall well-being. Pelvic health refers to the proper functioning and well-being of the pelvic region, which includes the bladder, reproductive organs, bowel and muscles, and connective tissue that support them. When pelvic health is compromised, individuals may experience a wide range of conditions that can significantly impact their quality of life. This slide depicts a number of conditions that are related to pelvic health. Despite its importance, pelvic health issues research highlights the need for a health equity-based framework in postpartum pelvic floor care by addressing systemic barriers affecting historically marginalized populations. This calls for sexual health equity support, shifting to models that consider social determinants of health, systemic racism, and access to care. As pelvic health awareness grows, there is a key opportunity to reduce stigma, enhance education, and create culturally sensitive systems of care. Now that we've laid the groundwork for understanding pelvic health, we're excited to turn it over to our panelists and begin the conversation. May and Kelly will now lead us through a series of questions that explore the unique perspectives, experiences, and insights our panelists bring from their respective fields. May, would you like to start us off?
Thank you, Kristen, for that introduction. Hi. We're also thrilled to be joined by students and faculty from 8 distinct disciplines. I'm going to name them now: diagnostic medical imaging, health informatics, midwifery, occupational therapy, physician assistant studies, applied behavior analysis, physical therapy, and medical billing and coding. Your presence here today reflects the collaborative spirit that underpins high-quality, patient-centered care. So we have, let's click to the, it's not there? I thought we have a QR code. No, we don't have one right now. Okay, so what was supposed to happen was that there was a QR code for audience questions. And as we are having our discussion today, we would love to know what you're wondering, any additional questions that you wanted to ask. Maybe we'll get it back up and running soon. So there will be a QR code on each slide that you'll be able to send your questions in on, okay? Okay, so now we'll begin. As we explore how an interdisciplinary approach can enhance outcomes and equity in pelvic health, We invite you to consider the powerful potential of working with, and not just alongside, other professions in shaping the future of healthcare. To start us off, can you tell us a little bit about how you provide pelvic health care within your scope of practice and how an interdisciplinary approach can benefit patient care? Who'd like to start us off?
Thank you, Mo. Midwifery is a discipline that cares for women in all walks of life and all ages. And pelvic floor dysfunction is a very common problem that we face. And I feel like as midwives, the onus is on us to screen for those disorders. They're certainly underdiagnosed, and partly, or in big part, because they're under-screened for. You know, Dr. Allen had spoken to accountability and has spoken about time, and you know, those are big factors. You know, we need to take accountability in the role that we assume as women healthcare providers in making sure that we screen our patients for these dysfunctions and disorders. A lot of patients, women, clients will hesitate to bring these problems up for many different reasons, but the impact of having those disorders, it can be really detrimental to a woman's life. So I feel like the onus is on us to screen for it, to bring it up, and to create time and safe zones for women to bring up those concerns and those problems. And then after that, in addition to diagnosing and identifying those problems, you know, in addition to giving basic advice and evaluating the severity and diagnosing, we do have access to specialists that can address this problem in a much better way and specialty than I can, right? So I think it's certainly pelvic floor specialist as a specialty is super underutilized, and we need to create more referral and interdisciplinary practice to approach these problems and to refer our patients to them.
Yeah, I just want to, first off, thank May, Kelly, and Kristen for doing this because, as has already been noted, this is a topic that we don't talk about enough. There's a lot of shame, there's a lot of isolation. And people, you know, the sad part is that people suffer needlessly. But I want to put this out there, that if we as health professionals, if we open the door to discussion or, hey, are these issues that you may be dealing with in your life? What my experience has taught me, if you build it, they will come, to steal from the movie many, many years ago. People are suffering. Pelvic health, again, is a public health issue. There are millions upon millions of people that are suffering. So I think such an important thing, and I believe there's gonna be a later question, but I really feel it needs to be said now. A key onus is on us as health professionals. We talk so much about interdisciplinary care. Too often it's talk. We need to really communicate, because there's two benefits to that. The big thing is, one, it serves the client ultimately the best, but it keeps us more facile, it keeps us more engaged, it keeps us more curious. So the key thing, and if we as professionals open the door to others and talk about it, give them permission to speak, if we talk truly to each other and respect the unique contribution of each discipline, that will even address the issues of diversity, because we'll be learning from each other so well. And I want to give a shout out, though, to a key discipline that I have learned so much from in terms of pelvic health that's not represented up on the stage, as many disciplines are not, but I want to just acknowledge the role of physical therapy as well as really key players in pelvic health, right? Again, we all have a unique contribution, and that's going to be key to our success in any area of practice.
Good morning, everyone. Again, thank you guys so much for having us here today. That's an excellent question. I'm really excited to be here just to address specifically the importance of making sure that when we do make these type of assessments, that we're doing it through a trauma-informed care lens, right? The pelvic floor itself, as one of the students so eloquently described, is such a very sensitive personal space, right? And we know how important it is in order for a baby to be born, how much they have to pass through the layers of the soft tissue and the bony pelvis, right? understanding what previous traumas may have existed in that space can impact and or optimize whether or not we address those areas. So I think that making sure that we always reflect on what the person's trauma may have been, or just utilizing a trauma-informed care lens when we are asking these questions, it can help us get further much quicker and in a way that not only appeases the client, but also us. Thank you.
I guess just talk specifically about the ways that I collaborate with other healthcare professionals. In my private practice, I see a mostly perinatal population, but I often see people that are not having babies, have never had babies, don't plan to have babies, or had babies a really long time ago, and are coming to me with a wide variety of pelvic health issues. And sometimes all they need is to be seeing a pelvic floor therapist. They were referred by their primary care physician, or they were referred by their midwife, or they were referred by their OBGYN, or they were referred by their therapist, or they were referred by their psychiatrist, or they were referred by maybe a GI specialist. So it's, and maybe all they need is to really have some therapy with me. But sometimes there's things going on with people where I think there needs to be a medical intervention here. You might be a surgical candidate, or maybe you haven't already been to a therapist or a mental health therapist, a mental health professional, and that's a key component of your healing as well. So thinking about the ways that my work in sort of a rehabilitative lens can interact with maybe a medical lens, or maybe a mental health lens is really important to me, and trying to, and also, to speak to the physical therapy component. If someone comes in and I'm like, I think this is a real orthopedic issue that I don't have background in, I might refer them to someone who's a specialist in running, or a specialist in some other sort of sports rehabilitation, or something's going on that I don't feel that I have the background to support. So it's more about creating a lot of different people working together. Something that I really love about my work right now, which was mentioned in my bio, is that I'm like part of a midwifery team in a way. So there's 2 midwife practices that pay me directly to see their patients, which is really unique. It's actually there's not that many people who are even referring perinatal patients to pelvic floor rehabilitation. And then there's these 2 private practices who value it enough that they take a chunk of the cash that they would get from their patients and put it towards getting them a pelvic floor therapy consult. And it's a really exciting model that people are doing that. And I would love to see the possibility that we have these care models where a patient is not just seeing individual care providers, but that there's a care provider team with all different disciplines on it. And then not only does that mean that that person's getting that care, but it also means that I'm talking to their midwife and I'm saying, okay, this is what I saw, and I think it might impact their birth in this way. Or this is what I saw, and I think it might be contributing to the issues that they're having that you're seeing from a gynecological perspective or something like that. So that was a lot of different things, but.
Can I just add one more quick thing? Pelvic health, of course, is very personal, and trauma often connected. And people need one-to-one. But there's something else that we should be considering that I've worked with that's been very effective: group work, bringing people together with pelvic health issues and doing groups. So groups become an issue in terms of reimbursement, but the value of the groups is how people begin to see they're not isolated. Other people are dealing with these issues. And more than me, if I'm leading a group, how much they support and share with each other. And group process is a really piece, I think, of the puzzle. Because then you all of a sudden have a group of maybe 20 people that show up, let's say for a group, And they go out back, not only do they learn from each other, they go back into the community and share with their friends, right? So we start to open the door, we start to knock down those barriers and the shame. But again, group process is very effective in this. And I will also say, and I'm curious from everybody else's experience here, that in my work, I don't just focus on pelvic health, I do other things, as was mentioned in the intro, but the people I work with that have pelvic health issues, they do the practice, they do the work. They will show up. If you give somebody, many of you have gone for therapy and have been given a home exercise program to follow through on, right? How many people actually do that? But people with pelvic health issues, if they're given things from practitioners, actually do the practice.
Great. Thank you all for your answers. Very insightful about your different perspectives and experiences in the field. We just want to mention that on the slides, the QR code for any question submissions is available now. We'll be asking these questions to the panelists towards the end, later on during the Q&A. So some background for our second question. Pelvic health issues affect the majority of individuals who identify as women, with many experiencing an average of 5 symptoms each year, including bladder and bowel problems, pain during sex, prolapse, musculoskeletal discomfort, and research has found that 83% of women ages 18 to 59 experienced at least one pelvic health symptom in the last year. Despite the prevalence of these symptoms, they are often overlooked, dismissed, or normalized, leading many to suffer in silence until issues become chronic or life-altering. Today, we explore how early identification, education, and culturally responsive care can better address these concerns. And by working across disciplines, we can shift from reactive treatment to proactive, inclusive care that supports pelvic health across the lifespan. So our question to you is, given that a majority of people who identify as women experience multiple pelvic health symptoms each year, how can we improve early identification, education, and culturally responsive care to better address these pelvic health concerns before they become chronic or life-altering?
I mean, I think Instagram and TikTok and Facebook have had a pretty big impact, actually. The number of people that come in with some degree of knowledge about what's normal, what's not, what's common but not normal is really astounding. So I feel like for all the harm that social media does do to our mental health, there are some pluses that people are realizing that certain things going on for them are actual dysfunctions that they should be addressing. And I feel like there's a lot of healthcare professionals, midwives, physicians, OTs and PTs who are providing that sort of public service by creating a lot of content about all of these different issues.
I think the most important factor here in identifying the problem is just creating the time and normalizing these discussions. You know, often we are focused on problem-focused visits and we neglect to open up the conversation and create that comfort zone where there's no shame, humiliation for the patient to bring these concerns up. She had mentioned that she sees mostly clients of reproductive age. However, pelvic floor dysfunction, the percentage increases with age, right? So it's ironic that only younger individuals bring those problems up, maybe because they have abrupt problems or are more imminent. However, the older population, or as we get older, are often neglected. And in part, or primarily because we don't ask the question, how is your sexual life? Do you have any incontinence? Do you have pain? We don't ask. They come and we focus on, if it's an annual visit, on their pap smear and their exam, and that's it. We don't ask questions that we're supposed to be asking, evaluative questions and screening. These issues are supposed to be screened. If we know for a fact problems in early teens are at 10%, but increase to 50% by the time you're 80, then we should be asking these questions a lot more, and especially for aged populations.
I 100% agree with that. And also, too, I think in asking these type of questions, making sure that it is a safe environment for them to want to give you the right answer, right? Or to want to be able to share, to explore, like, what does it feel like when you're having sex? Like, do you enjoy sex? Or what type of sex are you having? What are you using, right? Sometimes starting off with, depending on what type of visit it is, starting off with open-ended questions like that can lead to the eventual problem that they're having, and therein lies the referral, right? And I also wanted to say, too, I didn't say this earlier, I never met Sonia until today, but I very often send clients to Sonia for pelvic floor therapy work for these types of issues and how it affects their pregnancy, their labor, their birth, and even in their postpartum period. I actually heard about her through another patient, and then therefore, after the client's praise of her started to endorse her to other people. But anyway, I say all that to say, what ends up happening is when we create a safe space for people to have these conversations, then we can actually address the actual problem that they're experiencing. Thank you.
So I think what you were sharing is that screening becomes really important within each discipline. How many of you, when you've gone to a yearly physical, whether it's a GP, gynecologist, urologist, well, maybe urologist might, but would ask the question at some point, so tell me, when you cough or sneeze, do you leak a little bit? Do you have an urge to go to the bathroom? Do you find yourself running to the bathroom? Occupational therapist, we deal with toileting. It's part of our frame of reference, right? Our practice framework. We also deal with sex and sexuality. Why not, when I'm doing my initial eval with a client and I have to assess toileting, wouldn't I just ask that question? So I can't speak to the other disciplines, but we need to do it. When I go for my yearly physical, I should get that question, right? Or even talking, why are we so afraid to talk about sex? You know, when I look at stuff about like sex, addressing sexuality and disability, and I look for videos, you know where they all come from? Europe. We're prudes as Americans, and we put unnecessary shame. It's part of our broader culture, unfortunately. So again, we need to take that lead. I also want to add something else. Most of what I've been hearing at the table has been women's health. Men have pelvises too. And I bring this up because one of the major providers of pelvic health rehab, that's addressed primarily for physical and occupational therapists, actually had to develop a course for men's pelvic health because the pelvic health therapists that were treating people were saying that 30 to 40% of the people that were coming through the door were men. And the other issue is ageism. Older people, as younger people, are dealing with health issues. And I was doing a group, and it was all about urinary incontinence. It was an 8-week program. And the second to the last week, predominantly older women were in the group. And one woman says to me, can I bring up the elephant in the room? And I had an idea of where she was going, but I let her speak. And I said, okay, what is it? And she goes, could you have a program that deals with discomfort with sex? So I then said to the group, is that something that all of you think would be of value? 100% they said yes. So you know what? Older people like sex too. So that just because somebody is older, if they didn't like sex when they were younger, as I always say, maybe they won't like it when they're older, but we can't be afraid to ask these pelvic health questions. We can't be afraid to address sexuality, regardless of age.
I actually wanted to address something you'd mentioned. We also have to recognize that sexual activity may decrease with age because of these problems and not the other way around. You know, if we don't address it, you know, it is the causative factor. And to address something else that you had also mentioned earlier, group and support care, that there is a lot of evidence and abundance to show that it's really effective. Midwives in particular have a group care model called Centering that cares for pregnant women, and it's literally a group of women sharing their experiences and going through care together. And we need to adopt this model of care to other disciplines and other issues and other age groups, because certainly the only way to normalize and destigmatize any issue is by, everyone sharing their experiences and make it become more humane and more, and show how common it is. But often it's too stigmatized, and, the causative factor becomes the normal, the result of that, factor becomes the normalization that we do on our end by not bringing it up enough. But certainly group care.
Thank you for your insightful responses on that. And actually, what you just spoke about right now is going to lead us really into what Georgette's already mentioned. We're going to be talking about trauma-informed care. And so I want to ask, or I'm going to mention a study that's titled Recovery from Psychological Trauma by Dr. Judith Herman, who highlighted the point that the core experiences of psychological trauma are disempowerment and disconnection from others. Recovery, therefore, is based upon empowerment of the survivor and the creation of new connections. Recovery can take place only within the context of relationships. It cannot occur in isolation. There is significant evidence that shows that pelvic floor dysfunction is often linked to trauma, and I just want to say that trauma can be defined in many different ways. And so some of them include adverse childhood experiences. It could include sexual abuse, medical trauma is a big one, as well as PTSD, and many, many other forms, right? Additionally, health providers must confront deep-seated distrust of medical providers that stems from exploitation of medical research, social determinants of health, and persistent health disparities which particularly affect BIPOC and low-income communities. So the next question is, while many providers actively practice client-centered care, and we as OTs really know about that, right? But providing care through a trauma-informed lens is a relatively new approach. And so we're wondering what role do you believe trauma-informed or trauma-sensitive care plays in the practice of pelvic health? Georgette, do you want to start us off?
Yeah, thank you so much for including that, which is probably what makes practicing midwifery even more mindful, because it's such an invasive practice, right? Especially when we're talking about the use of, for example, cervical exams, right? And learning how to do that in a way that doesn't disempower the client from us receiving data, right? In a way very similar to what Dr. Lewis was talking about, like that objective data, which we think is objective at least, right? Something that was really important in my education here at Downstate in midwifery was the fact that our professors actually had us think about, like, well, what is touch? And helping us to develop a script that does not have the word touch in it, because we know that that word in and of itself can be, for lack of a better term at this time, triggering, right? And so really having us think back, like, well, what does that look like? How does that translate in your practice? Really informed exactly how I practice today. So right now I'm a midwife at ULA, and listening to other nurses at the hospital that we attend births at really remark on how much we ask for consent in the way that we ask for consent before doing an exam. And some of them, because they're not used to seeing our practice, they may say that we take too long. We take too long trying to get that information, but what I want to impose on them is the fact that, what we're doing requires a lot of integrity. What we're doing requires a lot of space and patience and time to allow that person to receive the type of care that we're going to provide, and to make sure that we don't disrupt or cause any trauma by accidentally swiping against the clitoris, right? It's a very sensitive area when we're trying to get that information. So yes, it does require some time. But I think that here at Downstate, when our professor had us pause to think, well, what does touch mean to you, and how can you elicit or ask for that, for touch without using the word touch, really gave us a minute to pause. And so we're hoping that that's what we're doing for the rest of the community where we attend births, is that people actually take a moment to pause and think about how does that affect that other person when we do provide these standard types of tests like cervical exams.
It's interesting. Thank you so much. I love the way that you're talking about this. I will have clients come in, and I, of course, am very focused on asking for consent with touch, and they'll give me a blanket consent. They'll say something like, just do whatever you want. And I'm like, oh, okay, thank you. I'm going to ask every single time. And I'm going to need enthusiastic consent every single time because people are so used to, in a medical setting, becoming really passive and becoming sort of just putting the expert hat on the medical provider and saying, like, I'm checking out. I'm gonna just have you do whatever you need to do, and I'm just here. And if I'm dealing with trying to heal someone's pelvic dysfunction, that's going to be counterproductive, unfortunately, because I really need them to be a part of their healing process. And if their pelvic dysfunction is coming from a place of trauma, which, as you said, it often is, we're not going to heal. We're not going to be able to solve this issue continuing the same sort of trauma, in a way, of people not having agency over their own bodies. I want to talk about something else in terms of trauma-informed care, which I think you touched on too, this idea of relationships. So when I was in OT school here at Downstate, we talked a lot about therapeutic use of self, and it was something that everyone in my class was extremely confused about. What does therapeutic use of self mean? And I think it's actually become like the cornerstone of how I practice, which is this idea that who you are as a person has a direct impact on the therapeutic relationship that you have with your patient and on their healing. So how's my nervous system today when I show up to talk to my patient? How's their personality impacting me, actually? And allowing myself to register all of that information is pretty important. Grounding myself, breathing, body scans, checking in. And then all of that is going to be a huge impact. And I would say that for my patients who come in specifically letting me know, you don't always know why, if someone has had a lot of trauma when they come in, and you might never even know. But the people who come in who let me know, like, I'm here because of this thing that has happened to me, that it's a gift, because it allows me to, like, really drop into that place of being present, mindful, thinking about the way that my relationship with them is going to be a big part of our work together. Yeah, so I guess that's what I have to say about that.
I support everything that Sonia just said, is that two people coming together, the language I steal from Moshe Feldenkrais is the joining of two nervous systems, right? That we're meeting together, so much of what we bring to the interaction is really important. Now, specific to, like, people dealing with PTSD, I had the pleasure of attending a few workshops with Bessel van der Kolk, who's written extensively about PTSD, not specific to pelvic health, but it will apply here. Now, in my work, I do not do internal work. If there's internal work, I will refer a client to someone. But still, in the work that I do, I can put my hands, at times I may need to, put my hands on the pelvic region, right? And of course, that could be very threatening. But if someone's truly in that place with trauma, something from the work of Bessel van der Kolk, which I have taken to heart, is that sometimes in the very, very beginning, building trust, which we've been talking about, is important. So we can start, I will say sometimes to people, we don't have to deal with the pelvic region directly today. Because in my training, right? And the Feldenkrais training that I had, I can start with other parts of the body to gently influence what's going on in the pelvic region. That trust that can be established in that moment, I'm already using my clinical reasoning to address issues for that client, but I don't have to go right to the spot. I can work more broadly, more holistically with that person. And these are words of wisdom. The OT students have heard me say this many, many, many times before. And again, they come from Moshe Feldenkrais. So I'm just a good sharer of information. These are not original thoughts from me on any level, right? But he felt if you can change the sensory experience for someone, so I'm working a little bit more broadly with the person dealing with trauma, and they start to feel a little bit differently, that has the potential to influence how they think and act. So if I take that slower process in the beginning, good therapeutic use of self, really listening and work that broad way, that works with some people. I'm not saying that's the way you have to do it, but we need options because we know everybody's different, and that can be a viable option.
I mean, everyone has touched on really valuable points. I want to say that, trauma-informed care has many layers to it, and multidimensional, right? There's the provider perspective, right? And then there's the patient. And most of the time, in order for us to provide individualized trauma-informed care, centralized and individualized care, right? You have to listen, and you have to be very conscientious and deliberate in your choice of word and touch. But in addition to all of that, you have to also be very observant of the individual you're caring for, because most of the time you will have individuals that are aware of their trauma, but sometimes you don't. We've dealt with patients who have genital mutilation really early in their life and have not been sexually active, so haven't discovered what has happened to them. But based on the care that you provide, your observation, as a clinician, as a provider of care, you have to be observant, and you have to see body language, and you have to hear it, feel it, look for it in order to provide a very comprehensive, trauma-informed care. You have to look, you have to listen, And if you are so blinded by your time and your capacity and your productivity, you really might overlook something that is so obvious to you. So in addition to all what they said, we have to just pay attention. Sometimes that's all you need to do.
I do want to jump in with one more piece that fits in with this, that when there's trauma and stress, the pelvic region, the pelvic floor, is highly innervated by the sympathetic branch of the autonomic nervous system. So things get they go right to that region. So something that I love to start, I probably do this with every client that's pelvic health related, I start with breathing, because the pelvic floor is also called the pelvic diaphragm. And when we breathe, the respiratory diaphragm and the pelvic diaphragm need to move together, referred to as the dance of the diaphragms. So starting with the breath and just getting people to connect, to sense, to notice, to become aware of that part of the body, to feel that movement of the pelvic floor is a gentle way to begin. And that for almost any diagnosis would be perfect. There would be no contraindications for that. And the other benefit, it shifts the person towards the parasympathetic branch. And so that becomes the beginning of my session. Once the person's comfortable with that, we do that 5 minutes. Now they're ready. They've quieted themselves down. We're grounded together in that moment of that session, and we can move on to whatever the next steps might be. So breath, really, really vital.
Yeah, I would say I spend probably 30 to 45 minutes on breath in my first sessions with people. So it's pretty huge. Take your time if you can. I wanted to say one other thing. I had a thought, which was like during the period of time in which we were always masked in the clinic, I really noticed how difficult it was to read what was happening for people, and I started to be really explicit about it. I was like, I can't see your face, so you need to let me know what's going on for you, maybe a little bit more than normal. And because I still have clients who are sometimes masked for health reasons or just for comfort, it's the same conversation. So yeah, just to speak to what you're saying is like, there's a paying attention, and then there's like Also asking for help from your clients, even if they can't always say it. It's like, okay, just raise a hand or say and I'll know, or stop, or out, or done. Giving a lot of options for that communication to be possible.
Yes, yes. And I just wanted to add one last thing, too, to your points. I did a Spinning Babies Aware Practitioner training last year in an attempt to really understand or even integrate what I learned in midwifery school about pelvimetry and the pelvic floor in relation to the baby's position in the pelvis and all of those other elements. And something that they did a beautiful job, such a beautiful job exploring, was embodied consent, which I think is what my fellow panelists are referring to, and how rich that is and how it does provide even more information than the verbal consent that we often look for, right? It's such a beautiful piece of work. It's something that I recommend to any provider, especially birth workers or birth providers, to learn more about the pelvic floor through the art of spinning babies. But, and something else I want to also say, now that I have all these competing thoughts, the breath, oh my goodness, the breath and how it has so much to do with the pelvic floor, and even the capacity for someone to birth without using their breath is impossible. And how you can tell when someone is fearful of your presence or fearful of the experience for whatever reason, how their pelvic floor tightens, right? And literally the body will withhold the newborn from actually expulsion. So thank you so much for reminding me of that. Definitely use that in my work, but really excited to learn more from you guys too. Thank you.
Well, thank you all for all of your different perspectives. I think trauma-informed care, of course, goes beyond pelvic health as healthcare providers, and it's something we can all carry into whatever specialty we do end up in the future for us students here. So to give a little context for our next question, pelvic health is often narrowly framed as a women's health issue. So people with reproductive organs of uterus, vagina, or ovaries. You guys have kind of touched on this before, that of course everyone has pelvises, and that includes cisgender men, non-binary, and transgender folks. Although much attention is directed towards women with concerns and findings related to pelvic floor dysfunction. We did find this study that highlighted that transgender, gender nonconforming, and gender expansive individuals frequently experience discrimination in the context of reproductive and sexual health care. And along with this, a 2022 study in LGBTQ health found that up to 72% of trans men experience pelvic pain after starting testosterone therapy, highlighting the need for increased research and understanding of pelvic health concerns in the trans community. Which brings us to our next question, which is the belief that pelvic health is primarily a women's issue something you challenge through your practice or advocacy? And if so, how?
So in my practice, I don't work with cis men, and I haven't yet done training in working with trans women, so I tend to work with people who were assigned female at birth, but I never use terminology, not never. I try not to use terminology, especially public-facing, that narrows birth, pelvic health, to being a woman's issue, or pregnancy. So, like, I'm leading a retreat next weekend. That's a retreat for pregnant people. When I have clients, I, of course, ask their pronouns, but also when I meet them, especially if they don't identify as women, I ask them what kind of language they like to use to talk about their anatomy. In a weird way, it actually just doesn't feel all that complicated to me. It feels really easy to just be like, well, we all are people, including women. So, I don't know. I guess in some ways it doesn't feel that tricky to me. It just feels like, of course, I'm gonna include trans men, non-binary people, and women in my practice.
Like all aspects of healthcare, we need to reach out to all the different communities. So years ago, with Bill Gallagher, a very dear colleague, PT colleague of mine, we reached out in Manhattan, 13th Street, to, I think the name has changed now, it's called the Lesbian, Gay, Bisexual, Transgender Community Group, I think. And we tried to do a program specifically for that population of people, but unfortunately nobody came. But the center worked with us, but we realized we needed more input before. We need to hear from the voices of people about how can we better serve you, right? But I agree, Sonia, right, that working with anyone, regardless of how they identify in terms of pelvic health, is pretty straightforward in a way, but how we communicate and how we create that sense of safety and that the person feels that they are being respected and can feel comfortable and share, that's on us to figure out the best ways. And we have to reach out to people in the community. Community outreach is such an important part, and we have to be good listeners to better serve all populations.
So I think it's only a problem if you create a problem out of it. When we say individualized care, when we say patient-centered, they identify themselves. We don't get to identify that for them. So if you really follow that rule across, your entire care practice, right, it shouldn't be problematic, right? They identify. You don't identify what patients are and what their problems are. And if they identify a problem to be existent, then you have to listen. You have to address the problem. There are a lot of underserved communities, and I feel like, concordant care is an up and emerging phenomenon, and we learn more and more concepts are being introduced to us constantly, and we have to be open to learn them to provide that better care. So I think the only thing lacking right now in the provision of care is just a lack of knowledge and how to deal with these up and coming changes with all these new treatments, right, that haven't been well researched. But aside from that, I don't think as healthcare providers we get to tell anybody how to identify and what their problems are. They tell us that, and that's my perspective on that.
That's exactly, well, not exactly. What I was gonna say was that is that we as providers, we have to continue to remain curious, continue to seek out information, continue to learn more, read the research, right? Engage in communities that we are unfamiliar with, especially if we want to be able to say that we are truly providing like holistic care for all people, right? So I think that's probably my key takeaways, just to remain engaged and keep learning.
Thank you for that. As I'm listening to your responses, particularly to this question, I'm wondering if, especially linked with the medical trauma that folks are coming in with that we've been talking about, if you have had instances where you feel that you're here to provide and really listen and support your patients or your clients in a way that they want to, but if you witness coworkers or colleagues where it's not happening, are there ways that you have kind of addressed that? Because there are disparities, and even if you are addressing it, it is not being addressed someplace for these numbers to be so obvious, right? So I'm wondering if you could speak to any of that.
I think for myself, I'll say one thing that's very special about the space that I currently work at, these midwives and clinicians are almost as though they're handpicked, right? We all share the same ethos. We all care about all people and all things. Obviously, we have, some of us are, specialized in other groups than others, but one thing that we do well is we are very, very conscious about being trauma-informed in all spaces. So even as a Black midwife myself, if I see Black clients more often, I can let her know or let them know that they will be safe in the hands of any one of my colleagues because of the way that we are. Not only through our training, but through the discussions that we have weekly clinic meetings, we have weekly learnings, we have a research group, we have a book list. Like, we try to stay informed or up to date as much as possible. And again, if we're not individually an expert at it, we know that we can definitely send them to another person in our practice.
So I can certainly provide or share an experience that I had a few times regarding, negative experiences that patients have had in the past with other providers. And I would say, like, there's a limitation to what you can do at the moment. However, first of all, you just have to be very conscientious and deliberate in doing better during that visit. So, and then execute that, and hopefully that trauma is reduced, or it's no longer an expectation at every visit that that patient individually has. In addition to that, we as, educators, now I put great emphasis on that, because, there's often a lot of feedback. Oh, that exam was violent. Oh, this is the best exam I've had. It's always been a lot, more violent or rough or painful. And when I've done the exam, you get positive feedback. Oh my God, I've never had an exam like this. Is it, have you actually done my pap smear? But, advocating for the patient, teaching the patient how to advocate for themselves is one aspect, but also for the future healthcare providers, our future midwives, we put great emphasis on teaching them the gentle approach, and to be also, as we mentioned earlier, all of us to be very conscientious and deliberate in observing body language and creating a caring, safe space for patients at every exam and every intervention that you do for that patient. And also put great emphasis on avoiding unnecessary interventions, I would say.
Okay, great. Thank you for your responses and your follow-up question. I think it's, again, very insightful across all practices, whether it's based on gender discrimination, racial discrimination, et cetera, any of those disparities. We do have some questions from the audience, and this one is very much geared towards the OTs up here. What is the difference between PT and OT on pelvic floor care?
I think, like, in some ways a better question is, like, what's the difference from one practitioner to another? Individually. If you have 3 pelvic floor PTs, they're all going to practice real different from each other. If you have 3 pelvic floor OTs, they're all going to practice real different from each other. Everyone comes in with sort of their areas of particular interest, their areas of experience. I came in as like a former dancer, a yoga teacher, a breathwork teacher. So I think that my approach is probably really different than maybe an occupational therapist who decided to specialize in pelvic health who was a marathoner, or who used to work in pediatrics for a really long time. So I don't actually think I know what the difference between a PT pelvic floor therapist and an OT pelvic floor therapist is. I think it depends on the individual. We all get the same training. We all do the same, maybe a lot of people do Herman and Wallace as the continuing education training, and you're with this PTs, the OTs and PTs are together. There's many other trainings that you can do, visceral manipulation trainings, myofascial release trainings, corrective exercise trainings. So yeah, do you have another take?
No, I think you said it very well. I think that maybe years ago, back 20, 30 years ago, there was a focus so much on the physical. And there's been a nice evolution where not only is it about the physical, we look at behavioral issues, even environmental factors, so we take this broader holistic approach. So I think PTs and OTs are doing that today. There wouldn't be a difference in that piece. However, when we're working with people, like I said, I don't do internal work, right? So I would refer out. So let's say I'm working with somebody and I see there's an orthopedic issue, as you were talking about before, that may be a contributing factor, but it's beyond my skill set. Then I know, oh, but PTs get training in that. And maybe a PT might say, you know, there are also cognitive issues here. And I know OTs get extensive training in cognitive remediation and cognitive rehab. So maybe I'm going to refer that person to Richard, right? So that's what I get back to, that if we truly understand each of the disciplines, all of us, then when we're working with a client, we're all going to come across issues that, you know, the unique contribution of the PT, the unique contribution of the midwife is going to be the person I should be reaching out to.
Time for one more question? Okay. And so a question from the audience. What are some efforts that could be made to raise awareness to target populations who may not know that they can receive pelvic health support? Sure. What are some efforts that can be taken to raise awareness to target populations who might not know that they can receive pelvic health support?
I mean, certainly outreach programs. I can say that I annually participate in community outreach programs where we discuss, you know, annual health screenings and programs that are necessary to promote and prevent disease. There is often lack of access, but what this question regards, there's also often lack of knowledge that there are these services that are provided for these patients. So certainly outreach programs, but also taking and utilizing every visit as an opportunity to educate and let these, you know, your patient know you have access to all these, all this care and all these opportunities to prevent disease and address issues that you may have.
I, for one, in my practice, have now sent everyone who comes into contact with my care to a pelvic floor therapist, everyone. Whether they're coming in for perimenopausal care or if they're coming in for contraceptive care, I'm sending everyone, just want to make sure I emphasize that, to a pelvic floor therapist or occupational therapist to provide them with that additional layer of support that I know that I cannot, okay? That's one thing. And then secondly, I was going to say the barrier that I think that I'm facing in making these referrals is the fact that a lot of great providers don't take Medicaid, right? And that will forever be a barrier because there are a lot of clients that unfortunately cannot pay for excellent pelvic floor therapy out of pocket, which I'm finding that a lot of the really high quality pelvic floor therapists or occupational therapists that we're sending our clients to do not accept insurance. So then what happens to that person? I run the risk of sending them to a space that might be more harmful, that is not up to date on the way that I like to practice or we as a collective like to practice, and therefore imposing harm. So I think that if we can just figure out a way to mitigate that barrier or to break that barrier, I think then we have a chance to achieve more, because then they'll tell their grandmother to come with them, or they'll tell their dad, like, okay, look, I know you've been experiencing this problem. We know how long it takes for you to urinate. I just saw someone that I really like. They take our insurance. Let's go, you know? I think that that's something I know that's going to take some more time and effort, but I think that needs to be immediately addressed so that we can expand services. Thank you.
And I'd like to build on something that I'm already a part of. It's called Project ECHO, and I know the OT students have participated. ECHO, the acronym stands for Extension in the Community of Healthcare Outcomes, right? And the group here focuses on geriatrics, and it's all about educating health professionals to better serve older adults. And I want to put a challenge out here to me and all of us at this panel here. I think we need something in many medical centers, something like a Project ECHO that focuses on pelvic health, because pelvic health, as I said, is a public health issue, right? For men and women, if you take any pelvic health issue, there are millions of people suffering, right? And by doing that, these echo sessions, for those of you who aren't familiar, is a very interdisciplinary team where somebody presents a case at any one session. They usually have a consult question. And then each of the disciplines, as we're going through that session, shares from their point of view, their unique contribution, how they might approach that. So that means we're all learning, as I talked about in the very beginning, we're learning from each other. We're becoming aware of how we can refer people. As you said, now you're referring to OT and PT for care. And again, the clients are better served, which means we'll be targeting people throughout the community, because as we get better information, we're then better able to ask the questions as health professionals, which will reach everybody, depending upon where we practice and who we serve.
Sadly, that is all the time that we have today, and we wanted to say thank you to our amazing panelists for generously sharing your expertise, your time, and your passion. Your insights have helped us better understand the value of interdisciplinary collaboration and the importance of inclusive, equitable care across the lifespan. And to the students, faculty, and guests here today, thank you for listening, engaging, and showing interest in this vital area of health. We hope today's discussion sparked new ideas, challenged old assumptions, and inspired you to consider how you, no matter your background or discipline, can make a meaningful impact on pelvic health. Thank you again, and we look forward to seeing how each of you shape the future of care.
Okay, thank you, everyone. We're going to take a quick break to allow for transition. Next up are the faculty presentations. So, stretch your legs, and we'll start again at 11:30. Thank you.
I'm not doing that.
Ready up?
Hi.
Ready?
I think so.
Good. I'll do a quick introduction.
Oh,
just get
sure.
everyone in their seats.
Good. That's a great idea.
Yeah. All right. Welcome back, everybody. You can be seated, and we'll begin with the next portion of our day. And again, I just want to thank the panelists and the occupational therapy student moderators, for facilitating such a rich and insightful discussion. Let's give them another round of applause. Okay, so now we are moving to our next segment, which are the faculty presentations. Earlier this year, I think in January or February, we opened up submissions from faculty members to submit an abstract of their current scholarship or research. And the professors and faculty that you're going to hear from today went through a peer review process where their abstracts were judged by their peers and awarded presentation based off of its merit and the rigor of the study. So the first presenter I would like to welcome to the stage is Professor Susan Rachel Condon, who's here from the Midwifery program. Thank you.
Thank you, Evacona. Before we get started, I just want to really wholeheartedly say how much I appreciated the panel. It was wonderful. Pelvic floor health is near and dear to my heart. I do want to say I was a little surprised to see us as midwives listed under supportive care when we're clinicians, and we do refer people for pelvic floor therapy with both PTs and OTs. I want to say to the point that was made about affordability or people being able to get coverage, one of the things that I did, because I see so much pelvic floor dysfunction in my practice, is I decided during the pandemic, when things were kind of quiet, to do some additional training. And because midwives do internal work and can under our licenses, I did both an OT and a PT approach. And it was really an extraordinary experience taking these 3 courses. So I definitely suggest that the midwifery students and the midwives in the room keep that in mind as something that you can actually add to your practice. It's not outside of our scope to do internal work. So thank you very much for your attention. I'm going to be presenting on my doctoral research here. And this was a project that I decided to do as a student at Thomas Jefferson University in Philadelphia because I realized after being in clinical practice for a couple of decades that most clinicians think that their language and their behavior is appropriate all the time, and they think that they engage in shared decision making, but most programs don't teach it as a skill set. So I decided I wanted to do some kind of intervention to help with an interdisciplinary approach to to providing respectful care during the maternity care cycle, and particularly during labor and birth. So originally, I decided I was going to approach some of my friends and colleagues in New York City who run big midwifery services and see if we could get a day where we could do interdisciplinary education and have it be experiential and have people interact across the care roles in terms of who's involved in maternity care. And after several months of appealing to them and trying really hard to get this to happen, it turned out that nobody would say yes. And then I was running out of time. And I approached one of my professors who said, you know what, if you want to graduate, just do it with midwives. And I said, well, what's the point of just doing it with midwives? Midwives understand this. And she said, you'll see. So it was actually really prescient, and it was a great opportunity to create something that was going to be much smaller and much more replicatable if people wanted to do the intervention again in the future. And I ended up doing it with midwives and midwifery students. So the project is called Birthside Manor. This is my poster, which you can see at the end of the hall if you want to take a look at it. So when we look at shared decision-making as a concept, there is a lot of material in the literature. There are a lot of theories, there are models, there are validated frameworks. There's a huge body of literature about shared decision-making. So before I started, I decided I was going to write a concept analysis. So that would really kind of get me deep in the literature that exists about what has been done. And I also realized that my expectations around how this would go with working with midwives only was something that I had to kind of set aside and see how it worked. So I based the program in social cognitive theory, which is that old Bandura theory about observation, imitation, and modeling. That these are key aspects of how people learn, and people learn by observing behaviors in clinical education that they then replicate, and that kind of, if they're not particularly beneficial or respectful, they kind of get perpetuated in that way. So we also find that how people learn is affected by personal, behavioral, and environmental factors. And when you're talking about the environment where people are laboring and giving birth, there are a lot of moving parts, and there's a lot of change over the course of time. So my research question was about respectful maternity care, beginning with an understanding of this consent process, and that consent is not a signature on a form. Consent is an ongoing, unfolding process, and that people have the right to withdraw consent, and they have the right to consent to one thing at a time. So if you come in and you sign a consent form, it doesn't mean that people can do whatever they want to your body. So that was kind of the beginning place. And then to acknowledge that there's a lot of complexity around decision-making, where every time you perform a procedure or an intervention, it could change the outcome. It could change the way the labor unfolds. It could change the physiology of the person in labor or of the fetus or newborn. So again, what I found in the literature was that formal curricula in this area are lacking in both medical and midwifery programs. And I chose to explore whether, when I had to condense everything, whether a short interactive intervention would improve self-efficacy in the practice of shared decision-making. So what is shared decision-making? This is a formal process with many moving parts. It is considered a pillar of quality by both national and international policymakers and stakeholders, including the Institute of Medicine and the World Health Organization, and the American College of Obstetricians and Gynecologists, the American College of Nurse Midwives, both have extensive opinion pieces and recommendations about the importance of having this be an integral part of care. So then I came across this concept of equipoise. So the goal when you're talking about equipoise is to reach a state where the outcomes are likely to be equal, and the way that you get to the decision is entirely preference sensitive. And that is a really hard thing to do in the perinatal care cycle. All right, so when we think about childbirth just in and of itself, it does have the potential to be transformational or traumatic or anything in between, but it's never mundane. So this is a big deal that happens in the course of someone's life, and research has shown that, that birth planning during pregnancy is ideal when there are developing relationships with care providers and there's continuity of care over time. And that is something that really just doesn't exist easily in the systems of care as they are right now in our country anyway. So you really have this kind of the large public hospitals, you have large groups, you have corporations that have taken over smaller practices where everything kind of becomes more cookie cutter. So the possibility for someone to even see the same provider several times over the course of prenatal care has gotten smaller and smaller. And so shared decision making is hard to carry on as a thread unless it's really clearly practiced and documented. It promotes an active discussion process that contributes to enhanced relationship building when that's a possibility, and enhances autonomy in a way that doesn't set somebody who's pregnant against their newborn or their fetus or newborn. All right, so when situating my research in the literature, I found a number of similar studies that were performed in a variety of populations. None of these included midwives. And while these study sample sizes varied, you can see that they're pretty small, and that each one of them did have a longer time period, and they also measured self-efficacy at more than one time point. So in my intervention, it was very brief. So it was a pre and post test within that same day. These all had follow-up to look at whether the self-efficacy continued over time. Okay, for my study, the IRB approval was through Thomas Jefferson University in Philadelphia. That's where I was a student for my doctorate in midwifery. What I did was I adapted an existing self-efficacy instrument where usually that instrument was used for patients to measure their own self-efficacy for something where they have learned a new skill, particularly around things like self-care for diabetes. And in this case, we basically adapted it so that it was about provider self-efficacy. And I only found one really big, excellent study about provider self-efficacy that was fascinating. There wasn't a whole lot about that that was accessible in the literature at the time that I did my review. I ended up with 18 items that were derived from an existing validated model for shared decision-making. And the analysis was for the whole group, and then I broke it down into the midwives and the midwifery students to see if there was any difference in those two groups. And what I developed was a 45-minute presentation about collaborative decision-making models, where I talked about these are the existing models, and I talked about the literature. And then the participants broke up into small groups, and each group was given a case to work on, and they had a period of time to work interactively around that case. And then we got back together as a large group, and each group presented its efforts. And the topics were someone declining a cesarean section for a breech presentation at term, planning a vaginal birth following a prior cesarean section, and a client who had a prior traumatic birth after an induction of labor declining a routine induction because she was past her due date. So those were the topics. This is the sample. There was diversity in terms of the credentials and the work sites. There wasn't so much personal diversity because of where we were and the kind of events that people were coming to. 6 of the midwives participated, did hold more than one credential, and 12 of them worked at multiple sites. And this was the age, race, and ethnicity breakdown and the educational background breakdown. We had 71 total participants in 6 presentations in 3 different states. So I did some traveling for this, it was fun. We were in Massachusetts, Pennsylvania, and New York. And one of the cohorts was students here at Downstate. So for my results, this was not the surprising part. We basically saw not a significant difference between the midwives and the midwifery students. We didn't see a significant change in kind of your basic non-interactive skills, like when somebody chooses to decline care that's offered, how do you document that? That didn't really change very much. And there were no changes in skills that are kind of considered the hallmarks of midwifery, and you see them here: establishing rapport, listening your client's concerns, engaging them in care planning to the extent that they want to be involved, making empathetic statements, and conveying empathy nonverbally. So this is pretty much midwifery in a nutshell. The fascinating thing was that there was significant change in skills that have a high impact on decision making. They're sort of the more meaty kinds of skills, and the ones that can really, I think, in my opinion, are more likely to change outcomes. So we have providing unbiased education about assessments and related care options was one example of that. And that has the potential to make a really big difference. This is the skills where a difference was found. These are the 12. And you can see that they are the kinds of skills that require a little bit of time and attention and a lot more listening than speaking. Really being, the panel talked about the therapeutic presence of self as being a really, really significant feature of quality care. And I would say that that is what's kind of represented here by these skills. And then finally, there were some limitations to talk about. There were a couple of problems with the design of the demographic survey, and that led to some confusion and some incomplete data collection on the demographics. Also, because the PI was known to some of the participants, we can't eliminate the possibility of response bias. I certainly tried to avoid that, but you don't know if it's an issue and how people respond to these things. Also, based on the data and the qualitative evaluations that were given, where there were open-ended text boxes for statements about their experiences, the introduction of concepts and frameworks and this experiential group process did appear to be effective. I would say that in the future, programs like this would benefit from being longer and having more, and potentially interdisciplinary or interprofessional. That was kind of my dream. I think that would be amazing. I also think it would be helpful to continue to evaluate at more distant time points, whether people, because it's a perceived self-efficacy. They haven't actually gone out and practiced it and then come back and said, yes, I can safely say that I have continued to have improved self-efficacy. And in terms of implications, in the qualitative analysis, there were several participants who reported that they were surprised that there was sort of a patriarchal tone in their small groups, and they realized how much work people have to do about developing communication skills that are more open-ended and allow for different points of view. That was kind of interesting. And it further reinforces the impact of willingness and adapting to the tone of usual care. We really need to listen to ourselves in the way that we're speaking to people. My students will definitely recognize that I'm a person who says that when you're providing care, you should not make self-referential statements because the care is about them, not about you. So you would never say, take a breath for me or give me a push, because it's not about you. So that kind of trauma-informed way of speaking is something that is a skill set that we can learn and adapt and bring into our care as a pillar of quality. So I would say that education and innovations in midwifery can impact other professions, and that's because midwives work with everybody on the team. So if we are modeling these kinds of behaviors and this kind of communication, it is something that other people will notice, and if it is respectful care, then perhaps other people who didn't receive that kind of training or part of their education can learn from the modeling that the midwives can do. So this is particularly true in clinical settings, and that was my project. So thanks for your attention.
Okay, thank you. Thank you, Professor Condon. Next to the stage, I would like to welcome Dr. Adebonia Jumbo from the Health Informatics program. Let's give her a hand.
All right, while this is coming up, hello everyone. It's a pleasure to be here presenting my topic, which is very crucial at this moment in time. We all know that resource management is very crucial when it comes to humanity. And my topic today, the title of my presentation is the critical role of families in sustainable management of scarce societal resources. I'm looking at this from a theoretical and empirical perspective. Missing something. All right. I'm sure that you've heard in the news about managing resources. And every time we try to scramble about the resources that we have, resources are very scarce and also very limited. However, if we are able to manage it effectively, then we all can be able to survive. But sometimes you see in the news where a lot of countries are, battling because of limited resources, or in terms of oil or gas or whatever that come across in the news. Recently, in Burkina Faso, a guy named Ibrahim Traoré, who decided to take the challenge in his hand instead of making his country much better, decided to take positions in managing the resources of that particular country in their hand. So today we're going to look at what are the effective ways that family can get engaged in helping to manage these resources. So a quick introduction. Family are very instrumental when it comes to managing societal resources for sustainable management in Africa. And this is embedded in three frameworks. One of which is balancing the social equity, economic viability, as well as the environmental stewardship. And these three pillars emphasizes, the family systems, which enhances the societal resilience, how society, push back to make these resources available. Also have to foster ethical community advancement. Also addresses the immediate need, because sometimes we have this immediate need against the long-term goal, which is basically looking at the sustainable resource management. And lastly, the long-term responsibility in future generation. What are the future generation responsibility? How do those, especially for you guys who are graduating or will be graduating soon, how do you get involved in research, in resource management? So a little bit of background. Across the rural and urban area in Africa, family are not just the consumers of resources, they are also a change agent. They are very active when it comes to managing these different resources, land, energy, food systems, and communal labor. Also, they play a pivotal role in decision-making around farming practices. And if most of you do know that in Africa, there's very much, involvement in the family farming practice, which kind of gives a more organic way of farming. Also, they also engage in household consumption, the energy use, and the intergenerational knowledge transfer, which we're also going to look in depth. How does this, help to sustain the local ecosystem as well as their livelihood? And traditionally, family structures maintain resilience, okay, during this socio-economic stress, as well as, communal child rearing, elderly care system. We've also heard about this term that it takes a village to raise a child. Okay, so all this is part of the sustainability ecosystem. Family also are the structures that maintain resilience, okay, and they're also part of this movement of making sure that our resources are intact, at least it's sustainable to the next generation, not just what we have today or to those who are here today. But study shows that between 2015 and 2020, Africa has experienced progress in areas such as accessing safely managed drinking water. Also in the area of 4G mobile network coverages, and as well as electrification rate. So meaning the electricity has been one of the major issues, but at least it's getting a little much better because of different innovations in solar system and so on. However, in 2020, a study showed that 39% of the African population, right, sort of, have access to these services. 39% is pretty low, right? Which kind of underscores the continuous regional disparity and have a more pronounced rural-urban gaps. So between the rural area and the urban area, there is still much existing in terms of disparity. However, despite the family role in managing these resources, African families are disproportionately impacted by resource scarcity. You think that we have a lot of resource, but they are kind of impacted by this scarcity. And why is this happening? Due to many challenging factors such as political instability, poverty rate, climate change, variability, gender inequalities, weak institutional support, which often underrepresent this family underrepresenting in policy making and planning. And these challenges kind of encompasses and compounded more issues on sustainable practices, not just in agriculture, but as well as in health and the intergenerational resilience. So the research question that I try to look at is to see how do African families function as primary stewards in the sustainable management of societal resources. what are the challenges that they face, and what are some of the strategies that can strengthen these family roles. And the objective is to investigate the Africans' families' sustainability, management of resources, highlighting their significant and challenges that they face, and also recommend some of the actions as well as frameworks that we can use to empower families in preserving these societal resources. And how does this connect? This study kind of connect to family resource management, right, to the United Nations Sustainable Development Goal. And the agenda is to have the Sustainable Development Goal from now to 2063. And that kind of emphasizes how families make daily decisions and how that they can also, their daily decision can also impact the environmental sustainability, the economic stability, as well as the social equity. This study also emphasizes on knowledge transfer. So in Africa, there's a lot of knowledge transfer that do happen, and we, later down the road, we'll see how we can get involved. Ensuring that insight that was gathered from research are accessible for families, and not just family, but also communities and practitioners, just like every one of us here, working towards sustainable futures, because that is the goal. We're trying to sustain the resources for the future. These are some of the significance that family can actually have in sustainable management. Number one is to preserve indigenous ecological knowledge, support informed secular economics, as well as be the mediator and mediate behavior around conservation as well as consumption. And lastly, mobilize community actions for the environmental stewardship. This is a method that we use. We use the theoretical and empirical approach, which is using literature-based analysis. Okay, and this is some of the inclusion. We use about 4 different databases online to get some of the articles that have been written on sustainable resource management. So looking at this theoretically, there are different pillars. The first one is the ecological economy. This is this economic system, right? Uses this as a subsystem of infinite, right, ecosystem. How do we use the economic, right, as a subsystem in the ecosystem? Also commons management, which is again coming back to that, shared governance. This is the collective governance of a shared resources. How do we distribute these resources so that it is sufficient for everyone? The last one is family system theory, which is based on family, seeing the family as a primary unit, right, that can be involved in decision-making as it relates to resource management. So the overall finding that we saw in the literature, number one was poverty. Poverty is a big hindrance, right? So it indicates that percentage of people that are currently living in extreme poverty will continue to rise even in 2030, which to me is a really very sad news. And also 20% of the population are faced with food insecurity because of, there's so many security challenges. And 54% lack basic sanitation services, which is across the board is really a very bad news. And these are some other challenges: political instability, unemployment and insecurity, gender inequality and domestic violence, cultural influence, as well as parent-child conflict, which is really happening at a high rate right now in the African region. On that side area is substance abuse. Substance abuse is taking a really toll on the African region in order for them to sustain this resource availability. Climate change is another issue, and policy gap and intervention needs. So we look at this into different risk factors. The first one is looking at this as structural risk factors that looked at 4 different areas: political fragility, climate vulnerability, land, tenure insecurity, and educational inequality. So looking at the political fragility, right, where there's unstable governance, right, the long-term plan, which is a sustainable resource management, kind of fall through the crack because there is no policy, right, and also there is no implementation of any kind of policy. And when this happens, families do not have any other options, right, because they don't have any good leadership, but to rely on the current need, which is kind of a short-time goal, which is basically the survival needs. When it comes to land tenure insecurity, this is where families are not guaranteed property right. They lack incentive for sustainable land management practices. Okay? And this short-term, there is also short-term exploitation, okay, which become, the order of the day, becomes irrational. And when this happens, right, the long-term access to this goal remain uncertain, which create a really significant barriers to environmental stewardship. Climate vulnerability, there's increasing frequent and extreme weather issues, which create, again, some kind of unpredictability, right, in the area of droughts, floods, as well as shifting the seasonal patterns that is known in that area, as well as disrupt the traditional resource management practice and families that have been relying on this from generation to generation. The educational inequality, again, is looking at the limited access to sustainability education, right? And this prevents the adoption of the innovative resource management techniques. Gender disparities in educational access even compound this challenge even more, and particularly among women participation in resource decision-making. When we look at this in behavioral risk factors, looking at the short-term survival behavior, how do they behave, when there are this kind of restrictions? So overgrazing and deforestation, right, is driven by this economic pressure that they do have among the family, and they make that as a priorities over the long-term goal, which is, the sustainability. Gender decision-making bottlenecks. Of course, because of the exclusion of women from resource decision-making, despite the fact that they are the central pillar of household management, right? And the traditional gender norm, which is basically women at the back end, they don't have to come to the front end, right? And this is really making a very limited women participations in formal decision making, not just in governance, but anything across the board. And consumption pressure. So another behavioral risk factor here is the consumption pressure, basically looking at the economic distress, which kind of drive the unsustainable resource extraction, right? That instead of maintaining the resource management goal, what is done is usually to cater for the immediate cash need. And market pressure and economic vulnerability can also lead to this over-harvesting and deforestation of these natural resources. So we can see that behavioral factors, right, operate within a larger structure which has a constraint and helping to create these complex challenges that families do face in terms of balancing the immediate need with a long-term goal, which is sustainable resources. However, addressing this behavioral research on this behavioral risk, we need to first of all understand the social, economic, and cultural context in which family make this decision. Looking at the family resilience, we look at how women are involved in savings, right? How community health workers also volunteer, which this is where we can also come in as interprofessional folks, right? Looking at how the local health agencies or health promoters can involve in helping to educate folks in promoting and addressing these interrelated challenges that is facing them. And also the indigenous knowledge preservation, which is very crucial, right? Which is a traditional environmental knowledge system which helps to educate and transfer that generational sustainable resources. I'm going to learn a bit, my time is up. This is a metric table that we kind of put together to show you the different themes, looking at family farming and climate resilience, which is very important. We have to show family how to continue to, to be resistant in maintaining this resource preservation. Family-friendly workplaces and sustainability, family stability and environmental impact, and sustainable entrepreneurship in rural community, as well as the digital capacity, which is very crucial. So now, how do we come in as health professional? Looking at this from the lens of health professional, we need to engage, right, in making sure that this resource sustainability is effective in terms of looking at water resource management, looking at the water airborne issues, looking at climate adoption, agricultural sustainability, as well as household energy. So health professional, right, we serve a very critical role in preserving this family practice. And we also have to understand that using the trust that have kind of endorsed on the health professional folks, we can use this, right, as an opportunity to influence resource management behavior in helping to preserve, some of these scarce resources. The knowledge translation cycle, engaging academic studies, identifying some of the effective family resource management practices, also transforming these materials into something like apps, posters, using them as a training tools. Community monitoring as well, tracking adoptions and impact through the local health workers, which will help us to tell a little bit of the story, how this is making impact. Sector integration, implementation across health and education, and the agricultural system. So again, the knowledge transfer cycle here will require quite a collaboration across the board, right? In the area of academic, government, community sectors, right, which will help us really to create the tools that they will need to ensure that, the evidence base that we are going to continue to produce is acceptable. And the community workers, as I said before, they play a very crucial role in monitoring the implementation, which will help to provide the feedback to monitor how they are doing and refining some of these educational materials as well as the approaches. So what are the policy recommendations? We have to recommend policy at the family level, right, to promote the gender inclusivity, also at community level to strengthen the sustainability the health sector level to integrate the sustainability promotion into standard care practice. So we have to embed this into our standard care practice, teaching patients how to really utilize the resources that they have, because apparently it's also impact our health. The policy level will help to mandate environmental education in primary and secondary curricula. So the health sector will represent a very powerful that can look at different pathways in promoting sustainable management resources in terms of integrating the different environmental education, standard care practice, as well as training the health professionals. So what is significant to this? The families as resilience foundations, right, to help us to, to continue to make effective decisions, to help to, to create this resilience in making sure that, some of the environmental challenges that we face are catered for. And it's also supporting the family resource management capacity building, as well as the broader resilience. Strategic intervention point, looking at family behaviors, right, which offer a high leverage impact on the sustainability outcome. The theoretical foundation, looking at different approaches that is grounded in validations of these ecological and economic theories, which can really be embedded to increase the likelihood and the sustainability impact. So practitioners, like all of us here, who understand the significance of family involvement in decision-making, right? Making some of these, effective interventions, and also showing some kind of, respect and understanding the critical family roles, right, will help in playing a pivotal role in resource sustainability. So by integrating the traditional knowledge system with contemporary sustainability science, practitioners can also leverage the best as well as the best practice of both the approaches to address pressing environmental challenges. So of course, there is no study without no limitation. The database that was used was limited. We also only look at English language studies. And also, of course, because of this limitation, there's a potential selection bias due to the inclusion and exclusion criteria. So conclusion and future direction. We have seen that studies have demonstrated that family represent a very unique position in terms of sustainable management in societal resources. Also, families that adopt this sustainable resource management practice will behave in a very creative way, which evidently also create a ripple effect throughout communities as well as the ecosystem. Practitioners who also understand the significance of family role, right, in terms of decision-making, will make the design more effective to produce some, some interventions that is respected, right, and would also play a very pivotal role in terms of, resource stewardship. So integrating a traditional knowledge system with contemporary sustainability science, practitioners can leverage the best, both the approaches to address pressing environmental challenges. So what is the future recommendation here? As you can see, digital innovation was very limited in the findings. So we have to explore digital tools, looking at mobile interventions for family, and using that as a way to create a sustainable education. We can also use some of the studies to look at the behavior change over time to see how household is adopting to these interventions. Lastly, we can expand research into policy ecosystem that support sustainable family resource sustainability. Thank you, and this is my.
Okay, thank you, Dr. Jumbo. Next to the stage and last for the faculty presentations is Dr. Puneet Dhaliwal. Welcome to the stage. Thank you.
Thank you, everybody. Thank you, and a very good afternoon to everyone. Thank you. The mouse here is a little tricky. You can just move it with a finger, so I couldn't figure it out. Well, my presentation today is primarily a case report. And like you all know, our patients are one of our best teachers. So my case report is on vestibular migraine and benign paroxysmal positional vertigo, which you all call BPPV. It can be a differential challenge both for a novice as well as for experienced clinician. So I'm just going to give you a little brief on vestibular migraine prevalence, potentially affecting about 2.7% of the general population, high prevalence in females, and you can find them in young adults to the age group of between 60 and 70 years, and the attacks can last anywhere from a few seconds all the way up to a couple of days. And another thing I want you to know is that there's a 3-time increased likelihood of getting vertigo, that is BPPV, in people who have migraines. Some of the symptoms that are associated with vestibular migraines, that's vertigo, headaches, auditory symptoms. Something that is very unique to this subset of migraines is that people can experience earfulness, ringing in the ear, when they're actually experiencing a migraine. Dizziness is also reported at that point of time. And if any one of you has ever experienced dizziness, it's very hard to explain dizziness. The easiest way to say anyone, or especially to a healthcare provider, it's usually we say, yeah, I feel dizzy, but it's hard to explain. So some of the verbiage that's used by this set of patients is that they might feel lightheaded, they might feel that there's swimming sensation in their head, they can feel heavy-headedness in their head, they can feel bloating of their brain as if it's turning into a balloon, feeling of rising and sinking, rocking and swaying as well. They can even feel a pulling sensation. They feel like their brain's getting pulled in one direction. And motion sickness. I love this little emoji here, always reminds me that how we feel spinny and, motion sick. That's exactly how our patients are feeling at that point of time. So for those who don't know BPPV, it's the presence of having vertigo with certain positions. Again, the prevalence is higher in females, about 2.2, to males, 1.5 to about 1. And when we are doing a diagnosis for BPPV, there are 2 basic types of it. We either call them cupular lithiasis or canal lithiasis. And they're basically differentiated based on the amount of time patients experience that sense of vertigo. It can happen in any of these 3 semicircular canals, as you can see. It could be in the anterior canal, in the posterior canal, or in the horizontal canal. They usually have a latency, which basically means when you bring the patient into a certain position, slowly the vertigo attack happens, and then it resolves. But that attack, when it happens, usually lasts for either less than 1 minute, which is the most standard way BPPV presents, and it's called the canal lithiasis. When it lasts longer than 1 minute, that is called cupular lithiasis, and that's where people can get a bit confused. Am I seeing a migraine, or am I really seeing a BPPV? they'll have symptoms again, very similar to that of migraines. They will have a nystagmus, which is a motion that your eyes have, and they will experience vertigo. Vertigo, for those who don't understand the term, basically means that either the environment is spinning or they are spinning themselves, and they will also experience the sense of dizziness. And the interesting thing with BPPV is that about 20% of these patients will recover spontaneously at about 1 month, and it takes about 3 months, and 50% of these patients will feel better. Migraines, on the other hand, can last for the rest of your entire life. So what does the literature actually tell us at this point of time? So there's some literature review, as you can see on the right side of this slide. And when we compare these vestibular and oculomotor signs, which means we're looking at the eye for our patients, the nystagmus, if you see on both sides, you can see that positional nystagmus, such that we bring a patient into a lying down position, you will see a nystagmus. The smooth pursuits, that is the ability of the eye to track a target, that is impaired in people who have migraines, and especially it's the smooth pursuits that are found to be standard or generalized impairments such that it becomes choppy. They don't have a smooth movement of their eyes. And VNG findings, which are basically colorimetric testing, where you put hot air or cold air into your ear to figure out how the inner ear is doing. So during those testing, we have a camera on the patient, and if any one of you has seen the Oculus, that's exactly how the camera actually looks like. Bit claustrophobic for patients, but they have special sensors in there to test for the motion of the eye. SN stands for spontaneous nystagmus, that naturally that there will be a nystagmus, but again, the biggest finding there is that the positional nystagmus tends to be present in people who have migraines, and very similar in BPPV. So as you can see, it's kind of similar. So I wanted you guys to see what smooth pursuits actually look like. This is not the video from the patient.
Is much more often detected on clinical examination than unidirectional pursuit deficit. Omnidirectional smooth pursuit deficit is a non-localizing but sensitive sign of brain dysfunction. This jerky pursuit movement does not interfere with vision.
So as you can see, instead of having a smooth motion of the eye going left to right, there was a little bit of choppiness, and that's what you will tend to see in people who have vestibular migraines. That's okay. I'll play this one and I'll play that one. So use the mouse. So I click it. Sorry about that. This video that you will see will show you what the eye movement actually looks like when it comes to a patient who has migraines. as you can see, the eye moves upwards, and it's slow. That's what you will tend to see in people who have migraines. It's not a fast speed, so the velocity of the eye movement usually tends to be slower. Yeah, for the previous one. This one. And this is a typical BPPV nystagmus. As you can see how fast it is. Goes upwards, it rotates. So there are always two components that you will see in the eye motion. That's a vertical component and a torsional component that you tend to see in people who have BPPV of the posterior canal. So I think the challenge for me, I've been doing this for almost 15 years. The thought was still like, what am I really tend to see in my patients? Is it central, or am I seeing a peripheral vertigo, which means am I seeing migraneous vertigo attack, or am I seeing an attack that's coming from the ear? It becomes very important as a clinician, because if it's migraine, your treatment interventions change. If it's BPPV, it's very quickly resolvable within a week's time. So this is an introduction to the case. It was a 77-year-old female. You know, her primary complaints, they kind of started about a week ago before her presentation to me. And she had an increase in dizziness, imbalance. She had heaviness of the head. She had vertigo with lying down and getting up from the bed. She also had nausea. She had upset stomach for the last 3 or 4 months. This patient has osteoporosis, and she was given reclassed infusion and reclassed when has some side effects, and nausea and dizziness is one of them. But they do tend to resolve within 2 to 3 weeks max. But it was 3-4 months that she was getting that. And her MD disagreed that this side effect was coming from the medications. She didn't have any headaches at the time of evaluation, but she did have some sensitivity to light. And for MD, they thought it was BPPV, and she should go and seek physical therapy intervention for treatment of the same. She has a very complex primary medical history, as you can see. You know, she has ocular migraine. She had a history of thymoma. She has osteoporosis. She had GERD. She always had oral fullness that would come and go, and she was a worrier. And I want to highlight that because in migraines, that becomes a very important thing, because if you are stressed, you know, it can trigger migraines for people. She had a previous history of BPPV. I actually initially saw her in 2017 first, and she was coming into the clinic a couple of times, and she was fully resolved. So this time around, we got the ENT testing done. Everything was normal. For those of you who don't know Fukuda step testing, you ask the patient to stand in position, have their eyes closed, and march in place. It's not a very sensitive test for figuring out which ear is a problem. It tells you, you know, ears kind of tell you where you are in space. They had other exams completed for her, given that she had nausea going on and dizziness going on after that reclassed infusion, but her blood work, stool test, everything was normal. For physical therapy exam, she did test positive for BPPV on evaluation. She had a left-sided test positive. We saw that really fast nystagmus on arrival. But at 1 week, all I could see was this upbeating nystagmus that you saw in the video. And at 2 weeks, again, that upbeating nystagmus, no vertigo, but she continued to have nausea. So what were the results? At 1 week, I treated her at 2 separate visits in that week's time with specific maneuver that we use for BPPV. It's called Epley's. I'm sure some of you may have heard of that. But even at that point, her dizziness, nausea, she had mild imbalance, and some light sensitivity continued to stay at that 1 week point of time. At 2 weeks, there was no more spinning, but she continued to have that nausea, dizziness, and that positional testing had switched to upbeating. And given her signs and symptoms, I started thinking that she's probably going through a migraine at this point of time. Why was it not resolving? I wasn't sure. and she definitely had BPPV. So my treatment intervention now included lifestyle changes, and she had not seen a neurologist in almost 6 years, so we decided that she is referred to the neurologist and let them decide what they would like to do further with her. At 6-week mark, I gave her a call to figure out what was going on. She said her nausea had also started to improve with lifestyle changes. She loved dark chocolate every night, so she hated to forgo of that, but she tried it and she actually felt better. So for those of you who are unaware, migraines, there are certain lifestyle triggers, and cheese and chocolate and wine, there tend to be some standard triggers, and they are usually told by all of us who are sitting here, who will be going into the clinic, to our patients to keep an eye on them, because they can be one of the triggers for migraines. So I think the key discussion and the clinical significance and conclusion for this case is that, thinking about migraines and thinking about headaches is not what we really want to think about. There are some subsets of migraines where you can have vertigo attacks. They are called vestibular migraines, and their presentation can be very similar to that of BPPV given during our signs and symptomatology. Second, you want to think about that when patients are coming into you, you might start taking care of someone's BPPV, but don't forget the fact that they have an underlying problem, that of migraine. That was my mistake. I won't call it my mistake, but more of I lowered my guard for that migraine and never thought that nausea would be a part of that migraine itself. And really keep it in mind that both of these entities can coexist. And when you're not sure, refer your patients out for the neurologist to help them out. And that's it from my end, and here are my references. Thank you.
Okay, thank you, Dr. Dhaliwal. And that concludes the morning portion of SOHP Research Day. I invite everyone to go and check out the posters. We have bagged lunches, which will be handed out, and we will resume at 1:30 with the student presentations, starting with the Health Informatics program. So thank you, and enjoy your lunch.
This is like, oh, actually, it's actually not too bad.
This light.
Oh, this might be how we do it. This might be how we do it.
is gonna be moving and.
I actually hate for them. Why am I? No. It's all right.
Absolutely.
Please speak into the podium or hand. Oh, we could do. Hello? Ooh. Okay, I'm sorry. Sorry, I had to try it once. It's actually not too bad. I feel like. You know what? I'm just kidding. You know, it's not even good. That, you know.
This is the group. This is the HI group. Hi, good afternoon. Welcome, everybody. Welcome back. Hope you had a nice lunch and enjoyed the weather if you went out. We are going to begin with the second part of our day. My personal favorite, because the student presentations, and there's always so much excitement about, maybe doing one of your last presentations for some. So to kick things off, I want to welcome the student group from Health Informatics. Come on to stage.
Good afternoon, everybody. My name is Hannah Mompolo, and this is my partner, Jessica Matthew. And we will be presenting on the effect of health disparities and barriers on maternal health outcomes. To get started, maternal health it refers to the health of women during pregnancy, childbirth, and the postpartum period. Maternal health is a critical public health concern that reflects the overall well-being of society and the effectiveness of its healthcare systems. Despite advancements in medical care and technology, disparities in maternal health outcomes remain a persistent challenge, especially in the United States. In 2023, the maternal mortality rate, also known as MMR, was 18.6 deaths per 100,000 live deaths. Such disparities highlight the need to address underlying determinants, including access to care, implicit bias in healthcare settings, income inequality, and barriers to culturally competent care. Maternal mortality and morbidity rates among minority populations and these inequities are driven by a complex interplay of social, economic, structural, and healthcare-related factors that systematically disadvantage marginalized communities. Failure to resolve these inequities perpetuates cycles of poor maternal health outcomes and widens existing health disparities. As you can see here, this chart vividly illustrates the stark disparities in maternal mortality rates between the United States and other industrialized nations. The US MMR is nearly 3 times higher than of France or Canada. This disparity calls into question the effectiveness, equity, and accessibility of the US healthcare system, especially regarding maternal health. In our literature review, we found that Black women face significantly higher risks of maternal mortality and severe morbidity compared to other groups. This provides a conceptual framework for studying structural racism and synthesizes empirical evidence linking it to adverse maternal health outcomes. We also found that social determinants of health, such as living, working, and aging environments that influence maternal health outcomes. Poor housing, unsafe jobs, lack of paid leave, and limited resources increase stress and reduce access to prenatal care, worsening maternal outcomes, especially for older and marginalized women. Lastly, we found that health insurance coverage significantly influences maternal health outcomes. Health coverage significantly improves access to specialized, preventative, and primary care for women, supporting better outcomes in maternal and reproductive health. States that have expanded Medicaid under the Affordable Care Act have seen gains in coverage stability and increased postpartum care. Besides that, racial disparities still remain. Women of color face higher uninsured rates than white women throughout pregnancy and postpartum.
In this study, we're focused on identifying and analyzing the main factors that contribute to disparities in maternal health outcomes across the U.S. These differences in outcomes are not random. They're closely linked to factors such as ethnicity, geographic location, and socioeconomic status. This is a critical issue because unlike other high-income nations, maternal mortality rates in the U.S. are still rising. Our study examines the primary contributors to these unequal outcomes and assesses how they impact maternal health. So for this study, we're using a quantitative cross-sectional secondary data analysis design. Our main focus was to explore how ethnicity and geographic location impact maternal mortality across the US from 2018 to 2022. We used data from the CDC's provisional maternal death count, and that was compiled by the National Center for Health Statistics. To ensure consistency and comparability, all mortality rates were reported per 100,000 live births. The dependent variable is the maternal mortality rate, and the independent variables include the ethnicity and geographic location. Cases were excluded if they had missing information and in order to maintain accuracy. We used Tableau and Excel to visualize these public health records. The visualizations used help show state-level mortality rates, trends by ethnicity over time, and highlight states with the highest and lowest rates.
For analysis, our results were produced from maternal mortality data that was analyzed from 2018 to 2022. We grouped them by age, race, and ethnicity, and by state. The following slides coming up next depict trends over time in racial and ethnic disparities and geographic differences in mortality rate. These graphs specifically identify geographic areas with the highest and lowest maternal mortality rates, laying the groundwork for understanding regional risk disparities. First up, we have a heat map, which visualizes maternal mortality rates by state in the US with color intensity indicating the severity of rates per 100,000 live births. Darker red shades represent higher MMR, while lighter yellow shades indicate lower rates. The map shows that southern states such as Tennessee, Mississippi, and Louisiana exhibit the highest MMR rates, with values reaching up to 41.1. Western and north and eastern states such as California, Washington, and Massachusetts are shown to have significantly lower rates, closer to 10.5. States in gray indicate areas where data is unavailable due to reliability or confidentiality limitations. Building on the regional patterns we just saw, this slide offers a more detailed comparison of individual states. Specifically, it highlights the states with the lowest and highest maternal mortality rates between 2018 and 2019.
So this is a clustered bar graph that shows maternal mortality rates broken down by ethnicity. As you can see, Black women consistently experience the highest maternal mortality rate. The rates in this group peaked in 2021, reaching nearly 70 deaths per 100,000 live births, which clearly highlight a major disparity. In contrast, white women have moderate rates that fluctuate, peaking slightly in 2021 and declining back in 2022. Asian women had the lowest rates overall, remaining stable and consistently under 20 per 100,000. Hispanic women showed an upward trend in 2021, but experienced a decline in 2022. Overall, these rates in 2021 and 2020 coincided with the peak during the COVID-19 pandemic, which strained healthcare systems, limited access to prenatal care, and disproportionately affected marginalized communities. Our analysis observed the maternal mortality rates in the US significantly varied by ethnicity and geography. Black women consistently experience the highest maternal mortality rate nationwide, underscoring deep-rooted disparities in care. These disparities are driven by unequal access to quality care, higher burden of chronic conditions, implied bias in clinical settings, and systemic racism. Geographic inequities were also clear. Southern states reported worse maternal health outcomes, largely due to under-resourced systems and a failure to expand programs such as Medicaid. A comparison between states showed that California has achieved a lower maternal mortality rate through Medicare expansion and strong public health initiatives, whereas states such as Tennessee faced higher rates due to provider shortages and a lack of Medicaid expansion. Additionally, over half of US rural counties are classified as maternal care deserts, which means that they lack adequate services and force women to travel long distances for care, which often leads to fatal consequences. Insurance coverage also plays a critical role. In states such as Mississippi, which have high uninsured rates, they typically see worse outcomes compared to states such as Minnesota, which have broader coverage. These findings point to a need to implement targeted interventions that address both clinical risk factors and broader social determinants of health. Now, one key limitation of this study is that rates that were fewer than 20 maternal deaths per 100,000 live births are less statistically reliable, which introduces greater variability and wider confidence intervals. There was also limitations with potential sample bias from underrepresented or less populated regions. There was also a risk of selection bias due to inconsistent recording. Additionally, certain data was rendered unavailable due to recent executive orders.
In conclusion, our analysis confirms that maternal mortality disparities persist in the United States. While national maternal mortality rates have fluctuated over time, racial and regional gaps have remained consistent. To address these disparities, future research should include qualitative and longitudinal studies that explore the root causes, including structural racism, policy barriers, and access to care. Additionally, evaluating the impact of Medicaid expansion, studying maternity care deserts, and assessing the role of telemedicine and mobile health units could help develop more effective ways to help maternal health outcomes become better. And thank you for listening to us. We hope you enjoyed our presentation, and we would like to give a special thank you to Dr. Kaufman for helping us throughout this whole process.
Wonderful, thank you. Thank you so much for that. Did you get the picture? Next, I want to invite to the stage the group from occupational therapy. Come onto the stage. On that note, shout out to Marcos, Luke, CG, Calvin, everyone from communications and marketing, running the photography and video for us today. I really appreciate your work today. All right, welcome.
Okay. Good afternoon, everyone. My name is Elisa, and I worked on this project with Taylor, Madeline, and Gabrielle. We're in the occupational therapy program. So good afternoon, and thank you all for being here. We are thrilled to share the research that we've been working on for the past 2 years with Dr. Nuer and Dr. Seminger, who's our collaborator from the University of North Dakota. We had the honor of presenting this project at both the AOTA and ISOTA conferences this year, and we were very passionate about our work, and so we're excited to share it with you. So the title of our project is A Critical Analysis of Race, Gender, and Disability Representation in Occupational Therapy Textbooks. So our research stems from a broad issue seen across healthcare education, and that's that many textbooks in fields like medicine, nursing, and allied health have historically lacked meaningful representations of race, gender, and disability. That gap highlights the need to critically examine our own profession and determine whether or not occupational therapy textbooks reflect the diverse populations that we serve in practice. So OT textbooks often serve as students' first formal exposures to many foundational aspects of OT, such as different health conditions, therapeutic approaches, client populations, and professional values. Textbooks are generally trusted and authoritative educational tools, and they play a critical role in shaping how future practitioners understand care, build empathy, and develop cultural competence. When marginalized groups are portrayed in stereotypical ways, or if they're excluded altogether, these materials risk reinforcing biases that can persist into clinical practice. So now for our literature review. Studies have supported that textbooks can strongly influence how students understand clinical roles, patient populations, and standards of care. This in turn shapes their early professional identity and clinical decision-making. A study by Kalantari et al. Conceptualized a hidden curriculum, which is basically the unspoken lessons that students absorb from repeated exposure to biased content and educational resources. These implicit messages can reinforce stereotypes and shape students' attitudes towards clients, even if not directly taught. So when we take a closer look at the actual content of textbooks across discipline, we find narrow portrayals of race, gender, and disability. For gender representation, Deckman et al. Found that men in healthcare education materials were frequently depicted in active leadership roles, whereas women were often shown in passive or relational roles. A similar study found that in medical textbook imagery, women were shown in emotional or non-clinical contexts and were rarely shown in decision-making roles. So in terms of disability, Mosley and Gibson examined children's rehab textbooks and found that disability was consistently framed from a deficit-based perspective, often portrayed as needing to be fixed. Literature review shows that portrayals of individuals with disability tend to emphasize their limitations rather than highlighting their independence or participation in everyday life. Lastly, for racial representation, Pusey-Reed et al. Found that racial minorities are often underrepresented or misrepresented in nursing textbooks. And this pattern is also seen in other studies where most textbook figures are white, with minorities often depicted in stereotypical or limited roles, such as only appearing as patients. Louis and Wilkes found that light skin tone was overrepresented in 3 out of the 4 medical textbooks that they examined, and there was no imagery of people of color or dark skin tones for 6 common cancers in these chapters of the textbooks. Our proposed methodology, content analysis, was supported by many studies that found success in analyzing textbook images to quantify diversity and identify gaps in representation. So with this support, we move forward with our methods. We wanted to see if similar trends exist in occupational therapy textbooks, so we raised the following research question. To what extent are race, gender, and disability represented in primary textbooks in occupational therapy education?
So to address our research question, we conducted an image analysis of the 4 most widely used OT textbooks that we selected based on the MBCOT's 2020 curriculum textbook and journal report. These textbooks were referenced in MBCOT, which is the National Board for Certification in OT Exam Development, as they represent core entry-level content and knowledge. The total sample consisted of 1,148 images, which contained 2,429 individuals. We conducted an image analysis to descriptively analyze race, gender, age, disability, and provider status. Here you could see the textbooks that we analyzed, including a pediatric and mental health textbook. To develop the data spreadsheet and organize the images, we assigned each image a unique ID based on the textbook and page number. Each rater was randomly assigned to a group of images, and demographic characteristics were analyzed using visual cues. We recorded the number of individuals in each image, if faces were visible, and characteristics such as race, which we defined as BIPOC, standing for Black, Indigenous, and other persons of color, gender, age, disability, and provider status. We also noted the image type and category and any additional notes. The inclusion criteria for the images included those with realistic human depictions, whether a photo, drawing, or diagram. We excluded images without realistic skin tone and no human features. Unclear images were categorized as undetermined, and we used a group consensus for these subjective cases if visual cues were insufficient due to factors such as lighting, angle, and image quality. So moving on to our results, we identified the distribution of the 5 demographic characteristics and found that across the 4 textbooks, there were significant disparities in diverse representation of individuals in images. So here, this graph shows BIPOC representation broken down by each textbook.
The yellow represents non-BIPOC individuals, while the black and white lines on the bottom show BIPOC representation. Overall, across all textbooks, 81.47% of individuals were classified as non-BIPOC. Next, this graph shows the representation of age across each textbook. Overall, 64.31% of individuals were adults, shown in yellow, with very little representation of older adults and pediatric populations, with the exception of the K. Smith or OK textbook, which is a pediatric textbook. These graphs show the distribution of male and female individuals in each textbook, with the dark gray at the top being undetermined for unclear images or images without faces. Overall, 55.21% of individuals were female, shown in yellow, so there was generally more female representation in the textbooks, but not as significant of a disparity compared to the other characteristics that we analyzed. These graphs show the distribution of providers, represented by the black and white lines, and non-providers in yellow. Across all textbooks, there was limited portrayal of individuals in the provider role, with 82.17% of individuals shown in the non-provider role. And then here, these graphs show the representation of individuals with an observable disability or mobility impairment. The yellow represents non-disabled individuals, and the black and white lines represent individuals with observable disabilities. Overall, 79.25% of individuals across all textbooks had no observable disability or mobility impairment. Finally, across all demographic categories and textbooks, 24.13% of individuals were classified as undetermined due to unclear images or lack of faces shown.
Now that we've shared our overall findings, it's important to highlight how we ensured consistency in our data. Since we were coding subjective visual characteristics like age, race, gender, provider status, and disability status, it was essential to confirm that different reviewers were applying the criteria consistently and objectively. This image represents our inter-rater reliability scores, which reflects how well different raters agreed when coding the same set of images. As mentioned earlier, the images were initially divided amongst 5 trained reviewers, and then reassigned so that each of the 424 selected images were rated by 3 people. This process resulted in 1,272 individual ratings, which we used to calculate inter-rater reliability. To assess the reliability and consistency of these ratings, we used the interclass correlation coefficient, also known as the ICC scores. The results showed excellent inter-rater reliability. On a scale of 0 to 1, our overall ICC was 0.904. Indicating strong agreement amongst raters. The most consistently rated categories were age, race, and gender, each with an ICC score above 0.90, suggesting that these characteristics were the easiest to classify based on visible features. In contrast, provider status and disability status showed more variability across raters. These differences were largely due to image limitations, particularly when faces were not visible or when the images consisted of anatomical illustrations. These findings highlight the importance of image clarity and context in visual research and support the continued use of multiple reviewers in future studies to reduce bias and improve accuracy. Ultimately, establishing strong inter-rater reliability strengthens the credibility of our findings and contributes to the overall rigor of the research process. Our analysis revealed a clear overrepresentation of white adults without observable disabilities, most of who were depicted in non-provider roles across all 4 occupational therapy textbooks. This portrayal does not reflect the diverse populations that occupational therapists work with in real-world practice. These findings are consistent with previous studies in medicine, nursing, and allied health, which also represent limited representation of BIPOC individuals and people with disabilities in educational materials. We also found that females were represented more often than males, which may reflect the gender demographics of the profession. However, most individuals were still shown as non-providers, which could contribute to the narrow or inaccurate perceptions of occupational therapists' roles. Perhaps most concerning is that nearly 80% of individuals depicted had no observable disability, even though disability is the central focus of OT practice and affects 1 in 4 U.S. adults. This lack of representation raises questions about how well students are being prepared to work with individuals of varied abilities, including those with invisible disabilities. Altogether, these findings
emphasize the urgent need for OT educational materials to better reflect the diversity of both clients and providers. Without more inclusive visuals, students may lack the foundational exposure needed to develop cultural competence and provide equitable care.
While our study offers valuable insights, there are several limitations to consider that may have impacted our findings. One limitation is the reliance on visual interpretation to determine demographic characteristics such as race, gender, and disability status. Although we use a structured coding system, identity is complex and not always visually apparent. For example, individuals with non-visible disabilities or non-binary gender identities may not have been recognized in our analysis, leading to potential undercountings. Another limitation involves image clarity and context. Some images lacked facial visibility or only included partial body shots, making it difficult to determine demographic characteristics with confidence. While we labeled these as undetermined, this ambiguity affected roughly a quarter of the images. Additionally, although our final inter-rater reliability was strong, initial analysis involves single rater coding, which may introduce some subjectivity even with standardized criteria. In terms of scope, our study was limited to 4 textbooks, 4 of which are widely referenced in the MBC OT exam. While this is highly reflective of the OT education, it doesn't encompass all OT educational materials. Additionally, we didn't analyze case studies or author perspectives or terminologies. Despite these limitations, the conclusions we drew remain significant. Our results reveal a clear pattern. Occupational therapy textbooks overwhelmingly depict white, able-bodied adult individuals in non-provider roles. The underrepresentation of BIPOC disabled, older adult, and non-binary individuals raises concerns about the values being implicitly communicated to students through these texts. When learners don't see diverse identities reflected, it may impact their cultural competence, reinforce biases, and hinder their ability to deliver inclusive, equitable care. Looking ahead, there are several key directions for future research. First, we recommend expanding the scope of analysis to include not only visual content, but also written content such as narratives, learning objectives, and case studies to determine if similar patterns of underrepresentation persist. Second, it would be valuable to examine the impact of textbook content on students themselves. Future studies can investigate how exposure to diverse or non-diverse educational materials affects student perceptions, confidence, or readiness to engage with clients from varied backgrounds. We also suggest analyzing a larger and more varied selection of textbooks to paint a more comprehensive picture of demographic representations across OT education. In addition, conducting a power analysis could identify where certain demographics are represented, whether some groups appear more frequently in specific chapters or content areas to see the patterns within the textbooks. It would be informative to compare older and updated versions of textbooks to assess whether and how representation has evolved over time. These next steps are crucial for ensuring that occupational therapy continues to grow as a socially responsive, client-centered profession. We'd like to thank Dr. Nwir and Dr. Isinger for their continued guidance and support, and for making our research possible. Thank you.
Okay. That was wonderful, occupational therapy. Our next group up to the stage is from the Physician Assistance Program. I welcome you.
All right, hello everybody. All right, so my name is Chris Belcourt. I'm a PAS1. I'm up here with my fellow PAS1s, Giorgio Spada, Ben Rosenbaum, and Joel Banayan. We'll be presenting an interesting finding on non-obese diabetes in Bushwick's Hispanic population, as well as our call for early weight-independent screening. So this is what we'll be covering today. And just some quick demographics for the Bushwick neighborhood. Predominantly Hispanic, 65%, with the rest of the population being comprised of, in descending order, Black, white, as well as Asian population. Now, these populations are all significant in terms of their own contribution towards what we're looking at, but for the sake of our project here, we decided to go with the majority. However, future research would very wisely be done with other groups of demographics. So with that, let's just compare obesity and diabetes rates in Bushwick. So typically obesity and diabetes have a strong correlation with one another. However, in Bushwick, we see below average rates of obesity, yet above average rates of diabetes. Brooklyn as a whole, however, has more of a typical correlation between the two features, obesity and diabetes, where they go hand in hand, they're directly proportional. However, that introduces a question, why might this discrepancy be prevalent in Bushwick?
So now we're just going to give a general pathophysiology of type 2 diabetes and just explain the breakdown between insulin and glucose. So first, you're going to have insulin that's going to bind to the cells, and then it's going to lead to intracellular signaling. That's going to allow for the migration of the glucose transporter. That's going to go to the cell surface, and then allow for glucose to be uptaken into the cell. But in the pathophysiology, there are many different mechanisms that can affect this whole process. One being that the insulin from the beta cells is not properly being produced. Other can be the receptor itself that has an issue, or it can be the intracellular mechanism that I've stated. Okay, so now we have a question for you guys. Which type of diabetes is more genetic? Oh, sorry about that. So sorry about that. We have this question for you, and we just wanted to ask you, if you think type 1 is more genetic, we want you to hold up one finger, and if you think type 2 is more genetic, we want you to hold up two fingers. Wow, so I see a lot of ones. Well, contrary to popular belief, actually, type 2 diabetes is more associated with genetics than type 1 is, and that's the common misconception. Now, how is it associated with our group, the Hispanic population in Bushwick? Well, they actually did a study in the Hispanic population of the United States in general, and they did multiple different groups where they found gene mutations in the TCF7L2 and the KCNQ1 genes that led to either an increase in insulin resistance or decrease in beta cell function, which contributes to type 2 diabetes. Now, another key point in this study was that they also found that it had a stronger association in non-obese individuals rather than obese individuals.
Challenging the diabetes criteria. So as we see here on the left-hand side, in 2015, the USPSTF set screening guidelines for diabetics, and what they said was that people ages 40 to 70 years old should be screened, and the BMI overweight to obese greater than 25. So just to point out, the normal healthy BMI right now is anywhere between 18.5 to 24.9. However, they adjusted their guidelines in 2021, a few years later, saying that people should be getting screened at 35 years of age, which is 5 years earlier, and till 75 years old. And the BMI stayed the same. So this is something that we are highly advocating for, and this is part of our research thesis, that people should begin getting screened earlier so that they can be detected earlier and that they can start making those modifiable lifestyle changes once they get detected earlier on. And of course, when you widen that gap between 35 to 75 years of age, more people are going to be screened and caught earlier. However, unfortunately, people are still being missed, even though we have modified the age component. So who are those people who are being missed? So in the Hispanic population in Bushwick, younger adults with lower BMI are being missed. That can be because of they're not part of the guidelines, so this way they're being missed. Hispanic adults without high school diploma, many Hispanics in the Bushwick community are seeking to start working earlier as opposed to furthering their education, and therefore perhaps living in poverty due to gentrification, without health insurance, and those without a usual health care provider.
So now we're going to get into the consequences of delayed screening. So in this graph, you can see the age in which individuals are diagnosed within the Hispanic population and then the white population. And we can see that in the Hispanic population, they're being diagnosed at around the age of 44, while the white population around the age of 51.
But Giorgio, isn't earlier diagnosis what we are kind of going for here?
Yes, you're absolutely right. However, in this case, it's not because they're being properly screened for diabetes. Rather, it's because of the earlier onset of symptoms that they are being diagnosed with it. And that's why you also see that they, compared to whites, for every white individual that dies, there are 2 Hispanic individuals that die from diabetic-related complications. And now, what are those complications? So now we're going to get into the natural progression and the complications of type 2 diabetes. So first, you're going to develop, and naturally as you age, you're going to develop insulin resistance, and then also you're going to have a decrease in beta cell function, which will lead to an increase in post-meal glucose and also an increase in fasting glucose, which will then lead to macrovascular disease risk, which includes like stroke, heart attack, peripheral arterial disease, and then you're also going to develop microvascular risk, which is like diabetic retinopathy, nephropathy, and neuropathy. And we believe that in the Hispanic population of Bushwick, this is actually occurring at an earlier onset, and they're developing it, and that's why you see them being diagnosed earlier because of the symptoms.
So just to give a quick recap on what my colleagues were saying, we see that the Latino population tends to develop, they're not dependent on BMI in order to develop type 2 diabetes, as well as the fact that they generally develop these symptoms at an earlier age, as well as the complications, which brings us to our third and most important discrepancy, which is the increased mortality rate. So, as my colleagues presented the health disparities in the Hispanic population of Bushwick, we were also given the opportunity to develop some strategies that can bridge these components that are observed in the neighborhood. And when it comes to helping any community, there has to be some goals and objectives in mind. So what is our main goal? Our main goal is to reduce the delay in type 2 diabetes diagnosis of non-obese Hispanic individuals in Bushwick by the year 2027. We have 3 objectives, all of which encompass the cornerstone of earlier screening, and hopefully it will identify the genetic predisposition risk that Giorgio was just speaking about, and overall it aligns with our goal aligns with that of Healthy People 2030, which also aims at decreasing the screening age criteria. So our first objective revolves around community education and awareness, where we would partner with primary care physicians as well as some establishments, and the aim is to focus on non-obese Hispanic adults, and especially those that may have this genetic predisposition, to incorporate a provider-facing guide to identify patients at risk. We have developed a pamphlet, which Chris is going to explain later. The goal is to raise awareness and bridge the gap between Bushwick residents and providers, because we all know that will ultimately increase the better outcomes and prognosis. Our second and third objective are inherently similar, but there are some differences that are important. The second one involves targeting those that, to target individuals that are insured, that do have primary care access. The aim is to implement weight-independent screening by 2027, regardless of BMI, at the age of 30, to redefine risk evaluation and to prevent misdiagnoses. And the third objective is to address those that are uninsured. So the goal for this objective is to reach out to 600 individuals that don't have a primary care provider. And the aim here is to tackle barriers such as mistrust, language differences, and gentrification-driven displacement, which we see in this population. And we chose 600 uninsured as the target goal because it's often that these individuals tend to be affected the most, and we want to make sure that nobody is left out. So with that, I'm going to hand it over to Chris for the methods.
So how are we going to do this? All right, quick overview here. We're going to target the awareness campaign for public and providers, a primary care screening program, as well as a community-based screening program. We'll break this down a little bit more. So to address objective number 1, to increase awareness of non-obese diabetes, we're going to start out by administering and developing and distributing a bilingual infographic with both Spanish and English. We'll show you that in just a second. We're also going to roll out a social media campaign with the same educational materials, as well as develop and kind of distribute a practitioner outreach program where we focus mainly on the evidence-based and literature-based recommendations for our objective here. this is just a quick look at our infographic. You can see that it's in both English and Spanish, and it focuses on some basic statistics of type 2 diabetes, the need for early screening, and how they may be at risk. Just gonna skip ahead here. Here's it one more time. Objective number 2 is going to be addressed through a primary care partnership program using those adjusted screening recommendations, and we will track those patient outcomes longitudinally just by pulling reports from EHRs. And our last objective will be addressed very similarly, like Joel was saying. We'll be doing so, however, we're going to be doing so by going to our prospective patients who might be at risk here. Doing so at public venues like churches, cultural centers, and public places. These are just some proposed ideas for some primary care partnerships. On the top row, we just have some private practices in Bushwick. The second row is some WICOF-based facilities for primary care patients. And this bottom row is also along the same lines, however, they're community health centers. Okay, so we have Benny.
Okay. So here, this slide displays different barriers to action, why necessarily this might be difficult to adhere to these plans and goals and initiatives that we set. So health literacy barriers, so lower education and health literacy levels means less understanding of disease management and prevention. Language and immigration can be an issue. Trust in providers can also lead to barriers of action. Financial strain as well. Time off from work is a major barrier, and childcare responsibilities blocks healthcare. So essentially what that means is that these different components are going to make it more difficult to go through with the care once we set that earlier screening criteria and they are being diagnosed, because they don't have time to take off from work financially. The Hispanics in the Bushwick population are having more difficult times. So how do we evaluate these methods? So we need to have metrics to evaluate and track our progress and follow through with it, assessing awareness and knowledge change, evaluating clinical outcomes, and gather community and provider feedback.
So this is a brief recap of what we went over today. This is our references. We want to give a special thank you to Dr. McFarlane. He isn't here today, but he really helped us out here, and his guidance and time is very valuable, and we appreciate him. Thank you so much. And
Okay, there's the energy I was talking about. Next up, we have the student group from physical therapy. Maybe we... That's right, that's right. Welcome to the stage.
Hi, everyone. My name is Jess.
My name's Olivia.
I'm Andrew.
And I'm Carly. And for our capstone research project, we assessed and evaluated health and wellness, education, and accredited PTA programs in the United States.
So as healthcare professionals, physical therapists, and physical therapy assistants have a responsibility to guide patients' behavior, to promote lifestyle strategies for risk factor reduction, and prevention of unwanted diseases and illnesses. These diseases could include cardiovascular disease, obesity, type 2 diabetes, and mental health illnesses and cancer. According to RIP, these lifestyle strategies include regular physical activity, weight management, proper nutrition, smoking cessation, stress reduction, and mental health. These lifestyle strategies have been shown to have a positive correlation with decreasing cardiovascular disease, cancer, and mental illnesses such as anxiety and depression. According to MOCDAD, the leading cause of mortality within the United States are modifiable modifiable behaviors, and lifestyle choices. The foundation of health promotion, education for physical therapist assistants, is centered around the concept of a therapeutic alliance, referring to the partnership between clients and their practitioners. Studies by Haynes have shown that this therapeutic alliance creates a positive correlation to improve treatment outcomes related to pain, disability, physical and mental health, and satisfaction with treatment. The American Physical Therapy Association, the ATPA, outlines the critical role physical therapists and physical therapist assistants play in the promotion of health and wellness and the effectiveness of them as health counselors.
So while we were looking for similar studies to our own, we found that there was limited research that exists on the health and wellness education in PTA programs. However, we were able to find some studies that looked at the PT education. Dunleavy et al. Examined how population health is included in PT education, and the key findings were that 72% of the programs include population health topics, but only 38% have dedicated courses. The faculty face barriers like time and resources, but most believe that this topic is essential. Black et al. Studied patient perspectives on PT involvement in wellness topics. The key findings were that most patients agree that PT should discuss these wellness topics and act as role models for wellness. And many patients have not had these discussions with their PTs, but they're open to it. Jewell et al. Examined the practices and educational trends among PTAs. The key findings were 65% of PTAs engage in continuing education, 40% of PTAs desire advanced certifications, and 55% of PTAs face time constraints as a barrier. Overall, the PTA field is evolving, and standardized education is required to address changing educational needs. So the aims of our study were to assess and evaluate the accredited PTA programs in the U.S. regarding health and wellness topics within the curriculum, inclusion of teaching methods of how to monitor a patient's readiness to change lifestyle behaviors, extent and quantity of class and lab time dedicated to the health and wellness content and lifestyle behavior coaching techniques, any changes to health and wellness after COVID-19, methods to monitor student knowledge of health and wellness topics, incorporation of outcome measurements to assess students' use of health and wellness in their clinical experiences, and any barriers that prevent PTA programs in providing the knowledge on these topics of health and wellness.
So our study utilized a quantitative cross-sectional survey design in order to explore how wellness education is integrated into PTA curriculum across the United States. Now, this was framed from the lens of prospective physical therapists such as ourselves, as well as faculty and directors from PTA and PTA and DPT programs. Now, our target was all 359 U.S. accredited PTA programs according to the CAPD, the Commission of Accreditation for PT Education. And this is where our contact information for each program was sourced from. Now, we included all 359 programs that were accredited into our sample population, and we excluded all programs that were not accredited, were pending accreditation, or international programs. And this was to ensure that our measures of education were consistent. Now, the survey was a 20-item questionnaire that was developed from published benchmarks and also expert guidance, and in order to explore health and wellness domains such as physical activity, nutrition and sleep, stress, substance use, and more, all of which are directly related to chronic disease prevention and holistic care. Now, in order to ensure face validity, this was reviewed by 5 external PTA program chairs. So as far as how our survey was administered, it was through the platform Qualtrics with an anonymous link that was sent out to each program chair. The distribution window opened on February 11th, and this also included 2 email follow-ups and also phone calls to maximize participation. The estimated time to complete our survey was 5 to 10 minutes, so this was extremely accessible and efficient. The questionnaire format included Likert scales, multiple choice questions, and also short answers we collected data about the academic role of each program chair or faculty, the program location and setting, time allotted towards the health and wellness topics, and also instructional format. Next steps for our study will include descriptive statistics in order to evaluate overall trends in program responses and also wellness education across the PTA program and curriculum landscape.
So within our research, we had a response rate of 37% with a total of 135 participating PTA programs. Of those 135, 31% were located in the Midwest, 28% were located in the South, 22% were located in the Northeast, and 19% were located in the West. A total of 89% of the respondents stated that they agreed or strongly agreed with the fact that their program encourages students to educate patients and clients and the community on lifestyle and behavioral changes to promote wellness under the direction of a PT to their future patients. When evaluating how programs provide the knowledge to do so, 73% of the respondents indicated that their health and wellness education was threaded throughout their program. 20% indicated that it was incorporated into a course. Only 4% reported that it was a standalone mandatory course, and 1% offered it as an elective. The remaining 2% selected other with write-in responses that included community participation and the incorporation of exercises into some lab activities. What we also wanted to examine were the curriculum changes relative to current events such as COVID-19 pandemic. Through this question, we were able to identify that yes, some PTA programs did have additional health and wellness material, but in almost equal amount, with only one school making the difference, made no changes to their curriculum. Furthermore, we also wanted to examine whether or not program curriculums included content relating to a PTA's ability to monitor a patient's readiness to change with lifestyle changes using different methods such as the trans-theoretical model, stages of change model, and the 5 A's. And from the first statistic mentioned, 89% did indicate that their program encourages health and wellness education, but here we can see that 65% don't provide students with the ways to do so. Only 26% stated that they would do, and 9% were unsure.
So in essence, there is a growing support for PTA programs, support of wellness education, and that signals an encouraging trend towards preventative and patient-centered care. Now, over half, 54% of programs have made changes to expand curricular content relating to health and wellness education. However, a clear belief-practice gap remains. While programs value wellness education, few provide structured training in assessing patient readiness to change, and even less towards coaching techniques. Now, this disconnect tells us that although the intention is there, implementation has not fully caught up. This gap may limit PTAs in effectively delivering holistic and wellness-oriented care.
So possible limitations in our study, programs that do not incorporate health and wellness education into their programs may not have been likely to fill out the survey, as well as the opposite of those who are interested in it and have a familiarity with it may have been more willing to participate in the survey. There also is a risk for selection bias, so faculty members teaching health and wellness may have been more inclined to report with positive feelings, or such that program directors may have been unaware of how in-depth they were going in their coursework. So to conclude, with growing curriculum inclusions, PTAs are increasingly positioned to support holistic patient-centered care, they play a meaningful role in preventative health strategies, and drive positive behavior change through evidence-based communication tools. Further research should examine how expanded wellness education affects PTA students' competency, communication, clinical confidence during both clinical internships and early practice. We also wanted to take a moment to thank Dr. Ahern for all of her guidance and support with this project. Thank you.
Okay, awesome. Moving right along, we have our next student group. That's the students from the Diagnostic Medical Imaging Program. Welcome to the stage.
Hello, everyone. My name is Kayleen Rodriguez.
I am Shamaria Leons. Saba Aslam.
Jessica Shu. And today, our research study is evaluating AI applications in diagnostic medical ultrasound from a sonographer's perspective. And our principal investigator is Professor Richard Yanada. So for this research study, our main goal as a group was to better understand how artificial intelligence is utilized and integrated in the field of diagnostic medical sonography. As we know, artificial intelligence has infiltrated many aspects of our lives, but specifically for this field, as future sonographers, we want to see how artificial intelligence impacts our field. This leads to our first aspect of our study, which is the role of AI in sonography. For this study, we wanted to look at the role of AI in sonography, in particular with routine exam protocols across various modalities examinations. Our goal is to better understand and determine how artificial intelligence can help during these exams to lead to better diagnostic physician interpretation, as ultrasound is usually the first imaging modality to be done when a patient comes in for treatment planning. Our second aspect of our study is to look at measuring systems. For this aspect, we wanted to see how artificial intelligence works in enhancing standardized protocol measurements, improvement in image acquisition, as well as diagnostic support enhancement. We want to make a keynote that we are looking at the increase in artificial intelligence demand in healthcare to see how it improves hospital turnover rates, efficient workflows, and to see how it can create quicker results and better clinical interpretations for physicians and sonographers alike. Especially post-COVID-19 pandemic, as we know there's a large increase in ill patients, and we want to see how ultrasound exams are required to better visualize and identify diseases and pathologies, as well as becoming higher in demand and usage. Now we are moving on to our literature review across the various modalities of ultrasound.
Presented here is an overview of how AI was applied to echocardiograms to differentiate between Takotsubo syndrome and left anterior descending acute myocardial infarction. What's powerful here is that the AI zeroed on the same areas as the cardiologists and expert sonographers typically assess, like the apex and the wall on the mid-wall segments, but with exceptional precision. These two conditions were specifically evaluated because they often present with similar clinical symptoms but require different treatments, making them difficult to distinguish and frequently misdiagnosed. The study suggests that AI assists in the accurate differentiation of TTS and AMI, potentially leading to improved patient management by reducing misdiagnosis. The red and orange areas signify high relevance, meaning the AI detected these regions as most significant in making a diagnosis. This could present with wall motion abnormalities or areas where pathology is more pronounced in one condition versus the other. AI assesses the global wall motion patterns or specific ventricular segments that behave differently in TTS as opposed to LAD-AMI. The green and blue shades, while still relevant, they don't hold strong weight as the AI diagnostic algorithms. It suggests that the AI considers multiple zones but assigns various importance. The green and blue zones indicate AI's secondary interests, and they help with diagnosis, but they do not set for the main differentiators. We go into now our next modality.
The next modality that we are looking at for our literature review is the utilization of artificial intelligence in the field of gynecology. So for this research study, the sample population of 302 postmenopausal patients were taken with transvaginal imaging of endometrial bleeding as well as endometrial sampling. And the 302 patients were split into two cohorts. Cohort A, which was endometrial cancer and hyperplasia patients, and cohort B being benign conditions for the patients. So for the goal of this study, an AI-based algorithm model was created to determine the conditions based on a classification system. So it looked at, without knowing whether it was from cohort A or cohort B, it looked at a classification system based on echogenicity, texture, shape, and vascularity. So the AI-based algorithm then analyzed the transvaginal ultrasound images, and from that, it had a success rate of 0.86 for sensitivity and 0.87 for specificity out of a 1.0 scale in comparison to the physician segmentation model. So therefore, the AI-based algorithm model was quite successful in differentiating between endometrial cancer and benign conditions based off of transvaginal ultrasound imaging. And now we move on to our research question.
So our research was looking at how frequently and how effectively is artificial intelligence being applied in ultrasound examinations across general, echo, vascular, obstetrics, and gynecology modalities, and in what ways does it impact diagnostic accuracy and outcomes from a sonographer's perspective. To look at materials and methods, we distributed surveys through email and flyers, and we had the participants only be registered and currently practicing sonographers in all 5 boroughs of New York City, including Long Island. Now moving on to our results.
So for the results of our study, we will go over the most important takeaways, starting off with the ultrasound modalities that were currently practiced by our respondents. We had a total of 72 respondents for this survey. The majority of respondents at 30% were echo sonographers, and the least majority at 17% were GYN sonographers. Following, we wanted to see how long these diagnostic medical sonographers have been practicing in the field, and the majority of the respondents at 45% have indicated that they have been in the field for more than 10 years, with the least amount being at 13%, 1 to 3 years of diagnostic medical sonography experience. Our next aspect of our study that we wanted to look at is to see, does their ultrasound machines have AI-powered software integrated into them? So this was a free response question for our sample population. And from here, we see that 39%, which is the majority, stated that no, their ultrasound machines do not have AI software in them. There is a possibility that perhaps the sonographers that answered this aren't aware of the AI software systems that exist in their practice. And here are the responses that were given for this question, the various different AI software that they believe exist in their practice.
And then we start to curious how often the sonographer use AI tools in their practice. And the pie charts here shows the half of the response used AI software, but half of the sonographer will not use the AI software in their sites. By asking a question, do the sonographer think the AI measurement helped them during their exams? The pie chart shows 36% of the response occasionally think it helpful, and 28% of response plan to use the AI measurement in the future.
Our next question that we wanted to look at is, what is your primary reason for using AI in your ultrasound practice? The majority of respondents answered 40% that say, I do not currently use AI, followed by 25% saying to reduce scanning time, and 23% to say to enhance workflow efficiency. So these were our responses for the reasons that the sonographers use the AI software in their practice. And now we move on to our discussion of our study.
After looking at the most recent research studies regarding the utilization of AI in ultrasound, we learned that AI has advanced enough, now infiltrating the field of ultrasound. However, we wanted to look into which modality has AI affected the most and in which aspects. AI is currently able to create preliminary reports, detect, locate, and label abnormalities, take automated clips and measurements, and correct angulation of the probe during ultrasound exams. Our data showed that not much of these advanced AI applications are currently being used in the ultrasound field. However, the AI applications that are being utilized have shown to enhance workflow efficiency and reduce scanning time. AI use in ultrasound is present but inconsistent across modalities. So the most commonly used is echosonographers. The lack of training and familiarity with AI tools affects usage of patterns and trust. Confidence in AI's accuracy is moderate, with many users manually adjusting outputs. Barriers include limited integration, high cost, and workflow challenges. Echocardiography shows the most active AI utilization, followed by OB and general, respectively. Findings highlight the need for continued training and standardization to maximize AI's potential.
Of our limitations of study, a significant number of respondents use little to no AI in their modality, specifically vascular, sparse or missing data, limited detailed cross-analysis, example, AI availability versus usage, missing or incomplete responses reduce the strength of cross-tabulation comparisons. We're going to move on now to our conclusion and the benefits, barriers, and advancements. So our benefits are improved workflow. The key aspects of the benefits: improved workflow, and barriers are inadequate training. And for advancements, standardized education ranked the highest. This study presents a fascinating paradox in that while AI is designed to enhance accuracy and efficiency, the findings reveal that its current implementation often leads to additional manual adjustments and uncertainty, highlighting the gap between its potential and real-world performance. This research underscores the importance of widespread education in AI. Without it, AI's power in sonography risks fading into potential unknown. However, with it, we stand at the brink of a diagnostic revolution. This brings us to the conclusion of our presentation. We thank you for your participation.
Okay, here we are with our final group of the day. We have the students from the Midwifery program. Welcome.
We've noticed. Thank you. All right. Good afternoon. My name is Laura Raymond, and together with my colleagues Madison Del Toro, Brianna Hagwood-White, Jennifer King, and Jennifer Langman will be presenting on behalf of the Midwifery program today. And so we're going to start. Pregnancy can be one of the most joyous times in a childbearer's life. Nowadays, pregnancy is showcased openly in a myriad of ways, including gender reveals on social media, reality shows about teenage pregnancy, and rallies concerning reproductive rights. Though it comes with a great many changes, such as weight gain, mood swings, and the ephemeral maternal glow, childbearers are often overcome with emotions when they finally meet their baby. Surrogates, however, have an alternative experience as they do not keep the baby that they nurture. Despite undergoing the many changes and challenges of pregnancy, surrogates relinquish the offspring they nurture to their intended parents. Does this impact their mental wellness? If so, what is being done to ensure that a surrogate's mental wellness is preserved in the postpartum period? Our proposal seeks to explore the mental wellness of surrogates in the postpartum period by measuring and investigating the incidence of postpartum depression and its associated symptoms among surrogates. Our question: how does postpartum counseling impact the incidence of postpartum depression in surrogates? To which we hypothesize that surrogates that receive postpartum counseling will show a reduced incidence of PPD and its associated symptoms as opposed to surrogates that receive standardized care. With that, Maddie will give us some background and history of surrogacy.
So surrogacy is a means to bring new life into this world for others that may not have the means to do so. There's two types of surrogacy that we're going to be talking about today. The first one is gestational surrogacy. This involves the assistance of assisted reproductive technology, or ART, and the use of IVF, or in vitro fertilization. And an egg and sperm is taken from an intended parent, created into an embryo, and then implanted into a surrogate's uterus. And with this, the surrogate isn't biologically connected to this child, and then the child is given to the intended parents, or the biological parents in the end. There's also traditional surrogacy, where the surrogate is actually biologically related to the child, as their own egg is being used, and either a sperm donor or the intended parent's sperm is then used to create the embryo and then implanted into the surrogate's uterus, or then it's also used intrauterine insemination as well. And the surrogate is actually biologically related to this child and then given to the parents who are then the intended parents. There's two different ways why surrogates would choose this, two mainly different ways. One is altruistic surrogacy, which involves surrogates becoming surrogates just because they have an immense sense of pride that they're doing this for someone that may not have the means to do so, that can't bear a child. And they have an immense sense of pride in doing that for themselves. There's also commercial surrogacy, where the surrogate actually has financial gain in the surrogacy program. And the intended parents or government-assisted programs would help financially stabilize the surrogate while she's in this process. And we have noticed that surrogates that involve in commercial surrogacy have more of an incidence of postpartum depression because they don't realize the lasting impact that this can happen on them, and they just do it for financial gain. So surrogates can undergo the same amount of pregnancy complications and hormonal changes that any pregnant person can go through. Some of these pregnancy complications can include gestational diabetes or preeclampsia, which is high blood pressure in pregnancy. And these two complications can follow them later on in life. And later on, they can actually develop type 2 diabetes or hypertension, and this can follow them throughout the rest of their life. They also go through many hormonal changes during pregnancy and in the postpartum period. And because of this, they're at more of a higher risk for developing postpartum depression after delivery. Many surrogates have stated that they didn't have much support and counseling from healthcare providers postpartum. And because of this, they did develop postpartum depression. And this is where midwifery plays a huge role in preventing postpartum depression in surrogate mothers. What we're proposing is that mothers have a mandatory 12-week postpartum counseling period in which they can express their concerns about the surrogacy and about giving up the child, as well as just they can express anything in their life, including relationships, financial instability, anything. And it really just helps them express their concerns. And with this counseling, we can help identify postpartum depression early, screen them, and then refer them, if needed, to a psychiatrist or psychologist.
Hi, guys. I'm going to be doing a literature review. So we just wanted to kind of define postpartum depression first. So it's characterized as intense feelings of sadness or depression, or just feeling like you can't perform your daily tasks. And so this can occur from immediately after birth up to 1 year post-birth, and it can develop between 1 and 3 weeks. And according to ACOG, it affects 1 in 8 women in the US. So while we were doing our literature review, there's not that many studies that actually explored the mental health of surrogates, but a couple that we did see, mostly they were international studies in the UK and things like that. And so what we were seeing is that, especially in a study written by Yao et al., that there's many psychological outcomes that are associated with surrogacy. And as we explore their mental states, that a lot of the women in the Western world actually associated with a feelings of joy, accomplishments, and pride, and satisfaction. And then there was also another study that was located in Iran where surrogacy was mostly done for financial gain. And in those moms, we did see that there was increased risk of postpartum depression, maybe because they were doing it for not those altruistic reasons, but for financial gain because, they felt that they had to. And so basically, we're just really seeing that the research is limited, so that really makes our study here in the US really important.
Welcome. In this study, a mixed methods longitudinal design will be used to assess postpartum depression in gestational surrogates. A combination of quantitative surveys and qualitative interviews will ensure a comprehensive understanding of the psychological experiences of surrogates following childbirth. The quantitative data will measure depression severity, while the qualitative data will explore the surrogate's emotional experiences. This study will be conducted to statistically assess how postpartum counseling can affect postpartum depression in surrogates based on different criteria. This design is supported by prior research that highlights both the prevalence and underlying emotional complexities of postpartum depression in surrogate mothers. Our objectives are to measure the prevalence and severity of postpartum depression in surrogates, gestational surrogates, to explore surrogate mothers' emotional experiences and coping mechanisms in postpartum, to understand what role postpartum mental health counseling will play in the incidence of postpartum depression, to identify key social, psychological, and medical factors influencing postpartum depression risks in surrogates. Our sample size will be 100. We will recruit 100 surrogates, of which we will separate them. One group will have 50, and the other group will have another 50. And in the 50, one of them will receive postpartum counseling, and the other will not. In this group, we will also separate 10 participants from each group to get a deeper understanding of their experiences. Participants will be recruited from social media as well as counseling groups. Our study timeline will track surrogates from 3 to 12 weeks postpartum with data collection at 3 time points. The baseline will be week 3 postpartum, which will be the initial assessment of depression symptoms and qualitative interviews. Our midpoint will be done at week 8, while the depression reassessment and progress interviews. The endpoint will be week 12, where we will do a final depression assessment and follow-up interviews. Our inclusion data will include females aged 21 to 45 who have completed a surrogate pregnancy within the past 3 weeks, with no prior diagnosis of psychiatric disorders requiring hospitalization and willingness to complete the study. The exclusion criteria will be surrogates who have endured any stillbirths or neonatal loss, or who have high-risk pregnancies such as preeclampsia or gestational diabetes. Surrogates who are undergoing intensive psychiatric treatment for postpartum psychosis will be excluded. Our data collection methods will be, we will use a cross-sectional survey within 5 standardized survey instruments, which include the Edinburgh Postnatal Depression Scale, which is a 10-item screening tool, which is very prevalent and widely used in maternal mental health research, the General Anxiety Disorder method, the Perceived Stress Scale, the dimensional scale of perceived social support, the impact of events scale revised. All of the participants will complete the surveys online or via mail questionnaires. The questionnaires will be returned via mail or electronic mail, and we will provide pre-stamped envelopes. The ethical considerations. We will have an institutional review board approval, informed consent for all of our clients, confidentiality, everything will be anonymized, and identifying information will be stored separately from research data. The participants have the right to withdraw, and we will provide support resources.
I'm already getting my Oscar music, so I'm going to try to keep this short. All right, so thank you. So the exciting part is data analysis. To analyze our quantitative data, we'll start by cleaning processes, by eliminating anyone in the study who has been excluded, met the exclusion criteria, duplicate entries, or incomplete information. Those will be removed from the finite data pool. Our inferential statistics will begin by separating the instruments. So the tools used, the GAD7, the Edinburgh tool, they're separated and then divided by our study and our control group. Parametric t-test plots will be used with GraphPad t-test calculators to determine the mean and standard deviation of the two variables, which are our control and our study group. We've chosen the t-test tool. It has benefits for determining the difference in the means of the two groups, whether they're statistically significant rather than due to random chance. It's also well suited for a study group of this size. We will develop t-distribution tables to help to determine our p-value, which we expect to be less than or equal to 0.05, expected also to support our study's hypothesis and to reject our null hypothesis, which is no difference between the two groups. To supplement our p-value, we'll also be calculating effect size with Cohen's d formula. This is the difference of the two means divided by pooled standard deviation. So this will provide a standardized measure for the difference between our screening tools for both groups. There's a reference for the numerical association with the study sizes, which you can see there, and I'm not going to read those. All right, so for our qualitative data, excuse me? Wrap up. So very quickly, transcription software and manual transcription will be done for the audio recordings into transcripts, which will be reviewed, coded by multiple researchers to eliminate areas of bias or blind spots. Software will be used for axial coding, so we'll have further categorization, thank you, my friend, and identifying recurring themes and relationships in the text. We will interpret all of this data by posing our qualitative and our quantitative data together, comparing it with published literature, and researchers will be having very reflective reviews of the processes and our own data, and this will be included in our final assessment and reporting. Thank you, sir.
Are you gonna let me finish, or should we just show the slides? Okay. All right. We recognize that our proposal is very ambitious and has its limitations. Some things to consider are our small sample size, as it may not be indicative of the overall trend of PPD and surrogates across the United States. As such, the study may need to be expanded, repeated, or redesigned to better reflect a comprehensive understanding of PPD and surrogates. In conclusion, because he's rushing us, we love you though. PPD can affect as many as 1 in 8 childbearers. Are surrogates included in these metrics? I don't know. And if they are these trends the same among them? Research into the postpartum mental state of surrogates is lacking. While they are expected to withstand the same changes and consequences of pregnancy as natural childbearers, surrogates still need the same care given to any childbearer, but there is no unified system for the legalities of their services nor for the care to be administered to them. Although we hope that our hypothesis is proven, As with any research, we recognize that we must be open to any unexpected or contradictory findings, and that these findings must be openly discussed, reported, and contextualized so as to properly understand and guide future work in this field. Thank you for your attention, and sorry for going over time.
And special thank you to Professor Wiggins, Shakima.
Go Shakima, thank you so much for your support.
Okay, so we're thrilled to have you all here to celebrate the incredible work of our faculty and students across all the programs. And today is the day to honor not just the end result, the posters, but also the process, the late nights, the collaboration, the persistence that brought each project to life. And special thank you goes to our poster judges that reviewed all the submissions using the established criteria and selected top posters from each program. And now I'm delighted to announce the winners. From the physician assistant program, the winning poster is Uncovering Genetic Drivers of Non-Obese Type 2 Diabetes in Bushwick's Hispanic Community, a call for early weight-independent screening. Congratulations to Joel Banayan, Christopher Belcourt, Ben Rosenbaum, Giorgio Spada, and their principal investigator, Professor Andrea Trimmingham. Okay. From the physical, congratulations. If I mispronounce your name, please correct me. Okay, from the physical therapy program, the top poster is Effects of Ulnar Nerve Neurodynamic Exercises on Ulnar Nerve Cross-Section in a Healthy Adult Population, an in vivo study using ultrasonography. Congratulations to Omar Abu, Aaron Bukalan, and Jordan Pickling, with their capstone mentor, Dr. Farhad Khairi. Okay. The next one is the occupational therapy program, and the winning project is the effectiveness of service learning projects in developing cultural competency in entry-level masters in occupational therapy students. Kudos to Julia Lavelle, Malai O'Keefe, Habiba Shafa, Cassandra Yu, and their principal investigator, Dr. Nancy Klein. From the Diagnostic Medical Imaging Program, the award goes to Evaluating AI Applications in Diagnostic Medical Ultrasound, a Sonographer's Perspective. Congratulations to Saba Aslam, Kayleen Rodriguez, Shermaria Leons, and Jessica Zhu, and their PI, Professor Richard Yanada. Well done, well done. Yeah, go get the group picture, yeah. Get the... Okay. And from the Health Informatics program, the winning poster is Analyzing Hospital Readmission Rates Across the United States. Well done to Brian St. R., Eugenie Estime, and Phoebe Okran, and their principal investigator, Dr. Kaufman. Okay, so let's give a big round of applause to all our winners and all our presenters. Thank you and congratulations, everyone.
Thank you, everyone. I wish you a good afternoon.